So if you join the meeting, you are consenting to us recording your image. If you don't want to see the inside of your house, turn your picture off, and I would be grateful if people would keep their microphone on mute when they're not actually speaking, so that we don't get to know about your Amazon deliveries and other things as the meeting goes on. So this is a hybrid meeting, so I have members of the board in the room with me here, and I have members of the board who are joining us online, but will be participating fully in the meeting. Try and apply this to myself as much as anyone else, and camera zooming around. I hope people don't get seasick trying to watch the camera zoom about. We've got a lot to cover in this meeting, so let's be pithy and to the point in our contributions. So thank you very much. So moving on to the first matter, which is apologies for absence. I have apologies from Baljit, who will join us for the private session but can't meet for this part. I've got Saeed, who is joining an hour late due to a commitment at Bart's Hospital. Raymond has given his apologies. Lobo has given his apologies, and Tracy Cottrell, who is our new interim CFO at Hillingdon, has given her apologies, and Gavin Newby, the deputy CFO, is covering for her. I don't think we got any other apologies.
I don't know if Nick's managed to get online, but Nick Gash is not very well.
Yes.
He might well be online.
So we may have Nick Gash, or we may have him with his camera off because he's poorly. So yes, thank you for that. Any others? Very good. Any declarations of interest that are applicable to this agenda, or that haven't made it onto our published updated declarations of interest? Okay. All board members' declarations of interest are on the North West London Acute Provider Collaborative website if anyone wants to check them. Okay, moving on to the minutes of the previous meeting. Are there any corrections to those minutes? No, I will take those as a. You were very tempted there, Leslie, aren't you?
I'm tempted, but I kept my.
Okay, maybe you could feed those back and we'll correct them later. In which case we will take those as a true and accurate record and memorialise them. And then we can move on to 1.3, the action log. We have two actions here. I think both of these are in process. So I think, Pippa, there's nothing to add on your first one, is there?
No, we have the first meeting of phase 2 of the EDI patient equity meeting in 2 weeks' time.
Great. Excellent. And Peter, we're putting the health and safety report on the forward plan. Yeah. So that's all good. Anybody else got any other matters arising from the minutes that they want to bring up here? No. Okay. Thank you very much indeed. In which case, I will then move on to our patient story, and I'm going to turn it to you, Leslie, to introduce it for us.
Actually, I'm going to hand it straight to our medical director, Roger.
I'm going to turn to you, Roger, to introduce it for us.
Thank you. So, Roger Chinton, medical officer at Chelsea and Westminster. Story today is from a patient called Avril, and we've got a short video which we'll show in a moment. And it talks about her experience accessing the same day emergency care or ambulatory care unit at Chelsea and Westminster. And I think what's important to note for the board is that Avril was a patient who was referred by direct referral from her GP. Really important new pathway which helps to truncate the stay that some patients might have in the emergency room to go in to see the appropriate specialist care team. And I think you'll hear from her and from one of our advanced clinical practitioners about how the access to the unit, the experience in the unit and the outcomes are improved in doing so. We can perhaps talk a little bit more about that after we've seen the video.
Thank you. Okay, thank you. I think that the people listening to it on the screen couldn't hear the sound on that, which I apologise for. We will post the video online so that people can watch it. I would like it opening up just a bit of a discussion now, because SDEX is one of the more recent innovations in the way in which we deliver emergency care, and we deliver them across all of sites. So, Roger, do you want us to say
I
something?
wonder if I could just bookend the video by just saying one more thing. And clearly you heard how positive that experience was, and the benefit in terms of improving patient flow.
For our watchers, can you just, in 2 sentences, summarise the experience of the referral from GP, so that people know what they missed?
So yes, I was going to get into that. So what we can do here is we get GPs to refer directly to a member of the team. The team recognises that's an appropriate referral, and then transport from the patient's home to the same-day emergency centre can be organised directly. We've got an additional model which North West London is piloting and is indeed championing, which is using the expertise of paramedics. If they're called out to a patient through London Ambulance Service, they can actually say, this is a patient who would be better served by the same-day emergency care units in each of the acute trusts. And using them as trusted assessors, we can direct those patients directly to the right point of care, the SDEC, rather than previously they were obliged to take the patient into our emergency departments for further assessment. So we've got 2 direct access routes that we've established, which are helping to get people to the right care more quickly and getting on to the appropriate experience, whether it needs diagnostics or, as you heard, early interventions.
Thank you. Very, very good.
Can I add one?
Please do.
Thank you. I mean, if you when we get to the
Leslie, better introduce yourself.
oh, sorry everybody. I'm Leslie Watts, Chief Executive at Chelsea Westminster. So the other bit of this is that when we get to the performance, you will see the emergency workload that's gone up, but the zero length of stay has gone up, and that is because in every trust, that model is starting to see patients that we would have admitted into an inpatient bed. So we can see that in the figures, in the performance figures as well, which is, I think, something that is, I think, well done, everybody, actually. I think there's been a lot of work around this. I think when we talk about winter, we'll talk about why this is so important.
Thank you. Any questions or please, yeah.
A couple of questions. The first one is, what would be the barriers to greater expansion of this and across all the trusts, of course? Make space would be one of them, but other than that. And secondly, you mentioned paramedics, but how much are we using other professionals such as advanced nurse practitioners, etc., in terms of facilitating?
So the paramedics are simply being used at a point of contact to direct from community, but we're using all of our staff to identify patients to be appropriate. I've talked about it very much as the first point coming into secondary care, but actually we're using it as a point of earlier supported discharge as well. So we'll be bringing some of our patients who we may have felt needed to stay in for a day or 2 longer to continue monitoring them. We're using the ambulatory services that we've got here to get them home, bring them back perhaps for some ongoing monitoring or interventions such as intravenous antibiotics. We're using, in that respect, we're using that to dovetail with the other initiative, which is virtual ward monitoring, where we can actually keep people in our purview when we've gone home.
Thank you. Any other questions or comments? Please, yeah.
Anita Manchandra, I'm non-exec at Hillingdon and Chel West. Do we measure the wait times in the SDEX separately from A&E? And do they have targets in the way that A&E does? So where do we capture that?
So we do measure that, and they are not nationally reportable targets, but we do keep a very close eye on that to make sure we've got the right balance of demand and capacity. That's one of the reasons why we've expanded the access to secondary, to the same day emergency care over 7 days and up to 12 hours a day, so that we can actually try and get the right balance on that. But we do absolutely keep a close eye on that.
Wait times are better than A&E.
Yes. Yeah.
A final point, and I'll make it from a national point of view, which is the most important thing is don't bed out your SDEX, because we know when we open those and we bed them and we put inpatients in, the number of patients you can put through each of those beds compared to an inpatient bed is many, many more. So it's a really important principle, and we have stayed with the principle in North West London.
I mean, we have pretty well all of our sites, our acute sites, have an SDEC on now, and I think there's a real sense that when we go into them, I get a real sense of all the patients are being treated all of the time who are there. Where when you go into an A&E, people are waiting for something to happen quite frequently. In SDECs, they've been triaged, they've gone there for a purpose, and they may be getting intravenous antibiotics, or they may be some other sort of treatment, but it has the hum of a place where there's action going on.
Just one last point from me, if you don't mind, which is I talked about better outcomes. One of the mechanisms that allows for that is that patients remain ambulant, they may remain moving around, they don't get confined to a bed space in a hospital bed. So deconditioning, which is such a significant concern, particularly with our elderly patients, is something that is avoided.
Tricia, you had a question.
Yeah, I was just sort of wondering if there's a capacity point you would get to, and also how you're encouraging GPs to use this process all the time.
Yeah. Well, I think with anything, there's always a capacity point. We haven't got to it yet. Looking out and making sure that we're alert to that. And we talk about this in our urgent emergency care board meetings across the integrated care system. So our primary care colleagues are part of that, but we're also doing some advertising through our local liaison groups that we have in each of the acute hospitals. We have meetings with our primary care.
Thank you.
I'll just add to that. So we've also got single point of access. So single point of access has been a game changer, really. So that's where you've got specialist nurses, consultants on the phone all the time. GPs can refer straight in, paramedics can call straight in. They can take advice, so therefore prevent conveyance. But also what they can do is send them straight to a surgical assessment unit like this. So the single point of access makes it much easier for primary care.
Thank you. Well, thank you for that, Roger. And if you could pass the board's thanks back to Avril for giving up her time and telling her story. That's excellent. And I think is a neat setup to our next conversation. Might be a little harder about our winter update and our urgent emergency care action plan.
So thank you very much, Chair. And before I hand over to Claire, who leads on this for the collaborative, it's no surprise to anybody, because this is playing out nationally, that we are very busy now. We are seeing winter levels of activity right here, right now, and we have the vast majority, if not all, of our bed spaces open. So it has been a real challenge too, but a challenge they have faced up to all of our crews that said, what else is it that we need to do, given the predictable increase in demand that we will see through winter, and what preparations have we made? We're asked to do this every year, and we learn year on year about the sorts of things we can do. You've just heard one of the examples, but a heck of a lot of work has gone into this piece of work, and again, I pay tribute to the piece for doing that. So if I can, Chair, I'll hand over to Claire.
Thank you. Claire.
Thank you. Good afternoon, everyone. I'm Claire Hook. I'm the Chief Operating Officer at Imperial, and I'm also the lead Chief Operating Officer for Urgent and Emergency Care. So as Leslie said, actually, this paper builds on work that we've been doing probably over the last 18 months or so, some of which we've spoken about here, and the detail of which we've done through the Finance and Performance Committee. The paper centres very much on NHSE guidelines, and the reason it does that is because the NHSE guidance actually is based on evidence-based practice about how to have the best possible urgent and emergency care flow through your A&E departments, UTCs, SDEC departments, etc. And we are largely compliant with that guidance. And in fact, we were just talking about SDEC, but some of the best practice happening within our EDs and our SDEC units is referenced in the NHSE guidance. So we're doing really well from that perspective. Collectively also, we're meeting the 4-hour performance standard that's set out in the operating plan guidance for this year at the moment, although we know that we need to do much better than that for our patients. And I anticipate we will continue to meet that standard as we go through the winter, even as Leslie said, though we're expecting the pressures to increase quite significantly. The paper says a little bit about what the ICS is doing in terms of preparation for winter, and clearly we have been a really key part in that. And it also talks about some of the risks that we're facing that are outside of our direct control. And the two key ones for us at the moment are discharge of patients who don't need to be in hospital for any longer, and waits for patients who need mental health input, most often are waiting for admission to a mental health bed. Although we have done a huge amount of work, as Leslie says, we can't ignore the context we're working in at the moment. So the vast majority of our winter beds have been open all year and are open at this point as we sit talking to each other today. Over the last few weeks, we've seen a notable increase in the level of pressure in our emergency departments and across our hospitals in terms of bed occupancy. And that's only set to continue as we go through the winter period. And of course, we're mindful of the challenge that we've got around our elective care pathways and the need to make sure that we're able to give patients who need their planned care, their treatment as we go through the winter also. So in summary, we've already done a huge amount. In terms of the guidance, we are as prepared as we can be, and as well prepared certainly as anybody else in the NHS at the moment. We've got really well established and well tested escalation processes, and we have agreed mechanisms for how we can support each other when we run into difficulty. But we are anticipating that the winter is going to be incredibly difficult, and our focus, as you would expect, will be on maintaining quality and safety as we go through that. And the final piece of the jigsaw, which is work in progress at the moment that Leslie's also alluded to, is the fact that we need to make sure that we've got agreed surge plans in place if the pressures become even more significant and we find that we need to create some additional capacity to accommodate the demand as it goes through the door. So that's a live discussion at the moment, which we will have concluded in time for whenever we need that level of capacity. So I shall leave it there, but very happy to take questions.
Let's open this up to questions. Steve first, then Simon, then AJ.
Thank you. So I'm Steve Gill. I'm the Vice Chair at Chelsea and Westminster. I had a couple of questions on this. In the paper, it talks about the fact that all of the London boroughs will have pathway 3 capability from September onwards. Is that now in place, and what difference is it making? The first question. And then the second question relates to what you said a few minutes ago, Claire, about the impact of mental health patients. And this is an issue that's come up in pretty much all of the quality committees and the collaborative quality committee about how do we deal with the fact that we are seeing more people with mental health issues turning up, probably in an environment where we're not able to provide them with the most safe and effective care. And how do we get the balance right between the acute sector and the mental health sector? So the pathway 3 first.
So thank you. So in terms of pathway 3, we, ahead of the whole rest of the country, actually have got an agreement now with our local.
The 10-section description for people who are listening in.
So I'm really sorry, I should have done. The pathway 3 patients are usually for our elderly, not always, but usually for our elderly patients that need to have need to go into nursing or residential care. So and they have some complexities of care. And across the country, there are capacity issues, particularly for some of our patients with cognitive difficulties. We've come to an agreement in North West London with the 8 boroughs, and a lot of that speaks to the work that each individual hospital does with their borough leads, actually, that actually the choice of where those patients go, if an appropriate choice is offered in hospital, they will go to that setting. And further choice will then, if they need it, will take place from that setting, rather than all of the choice decisions being taken in an acute bed. That will be very helpful for all of us, actually. And if that works and we can get that agreement to work, I think that actually that will, it's not so many the number of patients, often these are in relative terms smallish numbers of patients, but the length of time sometimes they wait can be long. And I should pay tribute to our local authority colleagues, because That has been something that they didn't have to agree to, but they have agreed to. So really grateful to all of those. So that has been, I think, something that, in terms of that has been something really good to happen. In terms of the capacity across the country, there are capacity issues, and there's a national discussion both between health and care about how we build that appropriate capacity. Claire, shall I leave it to you to say about mental health? I could go on, but let's hear a different voice, shall we?
Thanks, Leslie. I get there's two key lines of action in relation to mental health. So the first one is about recognising, I think it's 70% of patients with mental health needs who present to our emergency departments also need to be in an emergency department for their physical health needs. So our issue is less about the demand coming through the door, it's about the amount of time that they stay in the emergency department once their physical health care is dealt with. We are very focused on making sure that we put the things in place that we need to look after the patients as safely as we can in the environment that they're in. So there's been a huge amount of learnings across the collaborative about the ways that we might want to approach that and what the best staffing model is to support patients in that very busy environment when they arrive. The second piece of work is the work that we're doing with our mental health partners. So that ranges from lots of collaboration about making sure we're clear on escalation, we've got really good pathways in place, the communication works properly, and that we get the system to work as well as it can do. And then there's a more difficult conversation about demand and capacity and what we do when patients get stuck within the system. And our challenge back to our mental health colleagues at the moment is similar to the one we've just talked about in terms of our own capacity over winter, which is let's talk about a winter plan. Let's make sure that we've got the right level of capacity that we need. And it's fair to say that is still very much a work in progress, but it's something that we are actively pushing, and we're doing all that we can to support our mental health colleagues in designing those plans so that they work for all of us.
Thanks, Claire. I mean, I think I'd probably speak for the whole board when we say this mental health issue is one that we have been kicking around for the 2.5 years that I've been here, and it doesn't feel like it's getting better. And if at some point this needs to be a board-to-board conversation about the run up to winter, then you should call that, because I don't think we can afford to run through another winter. It's unsafe for the patients who are coming in, it's huge pressure on our staff, and it creates the wrong environment for an A&E department. So I do think this is something that the teams have been handling with enormous dexterity, but it has been going on for too long now. I think it's pretty fair to say. Simon.
Simon Morris, non-exec director, Hillingdon and London North West. Steve asked my first question was about social care and the relationship, and it's good to hear that relationship is established, although double moves for people that frail and complicated is not great patient care, and I acknowledge, we should acknowledge that. The question then is about the system thing, and maybe an appropriate question here, but clearly the idea would be to stop patients coming to the hospitals in the first place. And I suppose just obviously not directly our responsibility, but what are we comfortable and confident in the system are doing enough to prevent people coming to our front door in the first place?
I take a couple of inputs from Ned and then come back to you for that, AJ.
Thank you. Actually, it was also about mental health, and I was thinking about those who present with acute mental ill health, and I think it's really good that we're meeting the 4-hour standard, 78%. And it made me think about whether, as trusts, as 4 trusts, we need to have our own internal target around those who present with acute mental illness, because if we say that they spend twice as longer in our emergency department, then actually the 4-hour standard doesn't make any sense in relation to those patients. So I mean, that was one thing that was on my mind, and then the second thing was, obviously those with acute mental illness might present themselves with issues around self-harm, suicide, etc., and whether we have the capacity in our staffing to manage those sort of conversations and deal with those sort of patients. So the first one is really around the target and whether it's appropriate to have a blanket target for those particular patients. Thank you.
Thank you. I'm going to take Helen and then Bob and then let people wrap up. Helen, I'm going to introduce you properly when I get to my Chief Executive report, but welcome to your first board meeting.
Thank you very much. Helen Stevenson, Non-Exec Director for Imperial and Chelsea and Westminster. It's coming back to the mental health issues that we're facing. It's just whether it is actually people with acute mental health or whether it's people with very complex needs, of which one of which will be mental health, but it could be homelessness, addiction as well, in which case it's probably not just the mental health services that are going to be the key to that.
Thank you. Bob, last one.
Yeah, thank you, Matthew. Bob Alexander, Vice Chair at Imperial and Ned at London North West. I think this is so first of all, Claire and colleagues, can I just commend you on a very, very clear report, very, very helpful, very well laid out. Thank you very much. But there's a couple of things running through this, which I think when we receive further reports on winter pressure would be helpful for transparency. So I'm taken by the comment in para 4.8 about national guidance to do something. We have a local ICB that, for reasons I'm not completely aware of, aren't doing. And then we talk about the financial challenge that gives us as an organisation. We've spoken about mental health activity pressure, which we know from another place and other conversations, that is an inherent part of financial plans. We know that some of the discharge challenges we know are part of a financial plan. It might be quite helpful if when we come back with future winter plan updates, we try and make some quantification of what resource pressure for us means. That's not saying we shouldn't do it, but I think for transparency, we should try and be as clear as possible about what that means, which helps other people knowing what judgments we're having to make as a board to ensure patient quality and service. And I'm sure it's difficult, but it strikes me it feels quite important that we have a rounded view when we're looking at how winter planning develops in the context we're in.
Thanks, Bob. Did you want Claire want to kick those off?
Yeah, thank you. And I'm sure both Hughes and indeed maybe the finance officers want to come back. In terms of, thank you very much for asking about the pre-hospital, because everybody knows I love it. So we do know the sorts of things that need to happen in the community, which are IV antibiotics, falls, catheterization and end-of-life care. So thank you. And we are working very hard in the flow board to get not just our articulation of that in place, but how we do it. So we are working on it, and there is some commitment from the ICB to help us in terms of some of the funding around that. In terms of the mental health, our mental health patients, so there are some targets which we may or may not like, which is no patient. So they are seen and triaged and assessed in terms of psychiatric health quite quickly. That isn't the issue. The issue then is if there is a decision that says they need to be admitted, the length of stay then. There is a national target that says 72 hours. If we were to translate that into minutes or seconds, I think we'd start to say, what on earth are we thinking to have patients staying that long in the A&E? And a number of us are thinking about, we need to make that sound really unacceptable. And so there is some work that says if it's 72 hours or whatever it is, how are we working together, both as a system and actually as a region and nationally, to make sure we've got enough capacity, because these are, by that stage, the patients, if we made a decision they need to be either under section or admitted, that means that they are ill. They are very unwell and need inpatient care. So I think it's an absolute challenge and something we are working really hard at. One of the responses we get is in Northwest London, you're much better than many other places. I think that's not good enough. Yeah, particularly to those patients. So, and then I think if I come to the final one, and then I'm going to sorry, Helen. Yes, some of it is some other things like homelessness and those things. Those aren't the long waits in terms of waiting for mental health. Usually they may be waiting for housing quite a lot of our local authority are pretty good at alcohol and drugs issue around some of those, but we work very closely with our local authority colleagues around that. And then the bit that says, are we just starting to do the work? And I will just say this very quickly, and then other colleagues, Jazz and others, might want to come in terms about how we're doing this. So we already have done a calculation about how much the extra emergency work is costing. We need to be very clear about what we're counting and how we're counting it, but we will continue to do that so we can demonstrate when we talk about our financial position. This isn't just counting stuff that's block. This is more than block, which is, I know where you're going with that, which is actually. So I'll leave it at that. There are probably lots of other people who want to get a bit more detail around those things, and I might have missed something out, so apologies.
Julian, do you want to jump in on that?
Yeah, no, just thank you. I mean, I think we need to make sure we've got the same target for both physical and mental health, because they are patients who need those. And the large majority of patients, as alluded to by Leslie, do get seen and treated within 4 hours. The big standard after that is 12 hours. And really no patient should be in the department for 12 hours, either a mental health or a physical health patient. And that's what we need to try and really work towards, is reducing the 12-hour waits in our department, especially around mental health patients, but for all patients.
Thank you. Anyone else want to add anything to that, or do you want to come in on that specifically, Jazz, and then I will move us on to your item?
Yeah, I'm Jazz Thind, I'm the CFO at Imperial. Just in the context of the financial plan and those two work streams around mental health presentations and the cost to the acute sector, and also the no criteria to reside patients that are sitting in our beds actually should be somewhere else and moved on to more appropriate care. I think in the plan we had something like 11.3 million targeting reductions in spend, or securing additional income to offset that pressure. I think it's probably fair to say at this point in time we're not crystallising that benefit into our positions, which is partly why I suppose our financial position isn't where it is. It's not the only driver, but it does play a key part. And I think we're thinking through about 25, 26 now about how we have those conversations up front very clearly about what are the actions that would change that position for all of us. So I suppose it's just a recognition that I think we tried, and we are still trying through the task force to do good, but whether that crystallises in a financial benefit is yet to be determined.
Thank you. Excellent. We're going to move us on, and I'm going to move us on to you, Jazz, and the business plan progress report.
Thank you very much, Matthew. Actually, Jonathan very kindly pulled the paper together. So if it's okay, I was going to hand off to Jonathan to do a bit of a summary, but it's fair to say we set a number of priorities as part of our 24-25 planning. We've obviously revisited some of those and categorised them slightly differently or collapsed them into broader priorities. And I suppose what we're going to go through now is where are we against those, and probably some reflections about what we may do differently as we go into 25-26 planning. So if it was okay, I was going to hand off to Jonathan.
Just say I don't want to turn this into the finance conversation because we're going to pick that up later on the agenda. Yeah.
Thanks very much, Matthew. I'm Joe. I will probably know everybody. I'm Jonathan Reid, Chief Finance Officer at London North West, and I think Jazz has provided a really good and helpful summary. So there's a couple of things to say. The first is an apology. One or two of the pages at the back I've had a formatting issue, and so members of the public who've submitted questions on that, I will ensure that that is addressed for you. Some of the detail around the digital schemes was dropped off the bottom of the page. I think the report acknowledged it, and thank you for eagle-eyed colleagues who've been able to spot that. The second thing is that this was a bit of a transition year. So colleagues remember last year we were first go at pulling together an APC business plan. It took us quite a long while to get a clear set of objectives and work streams. They weren't quite as granular and as well defined as we would like them to be, but it was a good starting programme. Each of the CEOs had a leadership role across a grouping of those work streams, supported by an infrastructure. As we moved into 24-25, we have the process of finalising the APC strategy, which was confirmed in the early summer of this year. And I know that colleagues have been working through within both formal APC committee and within the Chief Executive-led working groups on refreshing and refining the various business plan priorities. So what we've tried to do is to summarise very, very briefly the movement from the last quarter to this quarter. At the last quarter, we had 24 priority schemes, 5 rated as green, 19 rated as amber. And I think as we all reflect, amber is a bit of a curse in a rating system. So but important to note the steady progress. At the end of Q2, we now have 30 priorities within the programme. The differential, the increase being that the work that's been undertaken to try and bolster some of those collective productivity and efficiency schemes. And a slightly different rating. We've got 6 as green, some really solid work on the digital and data side of things. A couple on red, and I think we need to be realistic. There's probably more that could be rated as red if we had greater specificity of our programmes, and I'll come back to that in a minute or two. And the core of amber or under development taking place. So I think the pack provides a summary of what's discussed each month at the Executive Management Board. I think the conversation of the board provides us an opportunity to reflect on some of the feedback from the committees as we move into the planning process, which is that a helpful programme, but not yet fully clearly articulated. And that's partly a narration issue. I've been remiss in terms of telling the story of what we've achieved in our business plan, but it's also partly about how we plan for pulling together the business plan priorities for next year. So I think as we start that process, it gives us an opportunity to really calibrate these for the coming year in 25-26. I did just want to highlight a couple of particularly solid areas of progress. I think for those colleagues who are involved with people services, the collation of a series of priorities into people services improvement programme, which is really green, has been really helpful and provides a really good and granular framework for challenge within a committee structure, but also across the 4 trusts. Green doesn't imply that we're meeting every objective we've set for ourselves, but it does mean we've articulated and clearly designed programme. I think the digital priorities, as I've mentioned, as said at the start of the year, solid progress, and I think we know this from our own experience across the 4 trusts. Bit of work to do on the federated data platform side of things. Finance and performance. Those aware of the financial position will probably question how there can be any green in there, but that is because there is a piece of work that we're trying to do on the sustainability and understanding the relationship between our underlying financial position and the financing streams with the ICB, and doing some work around support services consolidation. So there's a mix of green, red and amber in the finance side of things. And then quality. I think the amber rating belies actually some solid progress, and that takes me back to the point about having some specificity of delivery and outcomes. So Matthew and colleagues, I wasn't going to say a huge amount more on that. It represents an in-year summary at the end of Q2. I think the mixed picture reflects the fact that it is a challenging year, and there's a lot of work to do to develop some of our really significant collaborative programs. Thanks.
Thanks, Jonathan. Let me open it up. Steve?
Yeah, so thanks, Jonathan. On the productivity and efficiency ones, where we've got 4 that we've identified, I appreciate this is a summary level report, but it feels a bit light on targets, timelines, owners, given you know that we'll come to a detailed discussion later on a financial forecast. This one feels as though it needs acceleration to enable us to make some progress ahead of the planning for 25-26. Is that fair, unfair?
Not to say, so we have had that. I think we've had that absolute discussion, Steve, and agreeing together. And absolutely, that's the next step that we have to do. So I think that's a very fair challenge.
Thank you. Thank you. David.
Thank you. David Moss, Vice Chair at London North West and Ned at Imperial. Jonathan and colleagues, thanks very much for this. I think, if I'm honest, we're seeing quite an optimistic scorecard here, and I would encourage us next time to force them into red or into green, and I think we'll find there's more red than there should be. So could I just offer that? We need clearer focus on this, if I'm brutally honest. Thank you very much.
Tim, then Sim.
Sorry, just to pick up on Steve's point. So to your point about the efficiency, Steve, so we have the executive management board. We also have a joint executive board across the APC, and brought to the last meeting of that. And I think it's a good example actually of how we have, I think, slightly matured in our thinking as time has gone on. And I think one of the big issues actually was that we were not clear enough and specific enough what each project involved. And indeed, for some of them, I think there were different views between different trusts about where you should land. And I think so some of these clinical ones, for example, what actually is our stated APC view of what the critical care question is would be a good example of that. So I think we have thinned down the number, and we are going back around to say what exactly is it that we want to achieve here, and then we have also agreed a set of principles to apply to some of the important transactional things that we think we should be doing once across the collaborative.
Yeah, thank you.
Sim Scavazza, Non-Exec Director at Imperial and London Northwest. And thank you, Jazz. Thank you, Jonathan. And I suppose my question is along the same lines of, if you look at the red at system optimization, one has to ask whether we've been over-optimistic in the belief that we can deliver on some of these things. And do we need to be a bit more hard with ourselves, a little bit more focused in as much as less is more? So perhaps if we concentrate on fewer things but try to deliver the depth on those, then sort of, you know, a general let's all work together. So the reality of the mutual aid sort of agreement, that's what I want to say. Thanks, Tim, Leslie.
So really good point. So the issue about system optimization is that is whole system. So they were a group of schemes, and we will have a discussion about this, I suspect, when we come to the finance, that we had agreed with the ICB. The ICB were going to sponsor to help deal with a couple of the knotty problems we've touched on, actually, mental health patients and discharge of patients who don't need to be in hospital. And we have struggled to make progress with the ICB in getting the external input onto that. So I think we do need to think carefully about how we engage with the ICB around these genuinely system-wide approaches. So, that's the answer to the first bit. Your second bit, I think you're absolutely right. We got 12, I think, priorities. We had too many, and a part of the process that we went through the other week was to try and thin that down and to focus on the ones that are A, deliverable, and B, are material.
Did you want to add anything?
That was exactly my point. I mean, I think this shows the maturity of the APC, because actually what we're starting to deliver is in the gift of the APC. The ones that are not quite delivered is the ICB. It's the wider system. It's where we need mental health and local authority, and that's where we need to make our inroads next. But actually, the ones we have driven, the biggest and the most progress is within our gift.
Thank you. Yes, Benita.
Thank you for the paper. Just picking up on those points about the system. Given that seems to be where the bottleneck is, and I think the data indicates we've done as well as we can with what's in our gift. What is it that the oversight board might do to help alleviate some of those bottlenecks? Because I see that's chaired by you, Leslie. Does that have a plan of work, terms of reference? Can it help sort out?
Yes, it has all of those, and we've just had one meeting is all I'm interested in say. So, so yes, failed. It's going to be a little bit longer.
Well, we'll discuss it again in January then.
Exactly. So I think, and we had all, the four of us had a discussion about this that says it's not moving, particularly those whole system ones in the way that we would want. And to be honest, it was just a function of some of the national work that said, can you give it a go? And so we have made some progress, but there's lots more to do. The only thing I would say, and the others may not agree with this, there is still plenty more for us to do internally as well, is what I would say.
So funny, Leslie just picked up another point. So I wouldn't want anyone to go away with the idea that this is someone else's, it's your fault. But there is an awful lot that we have to do, and that process that we went through of thinning down, really focusing on the few that we think are genuinely going to deliver is a key activity for us.
I think that's wrap it up there. I think that's a very good place to end on, because the thing that struck me here is that clearly there are some complex stuff that run across multiple organisations which we have not made as much progress on this year as we wanted. But we also shouldn't build our plans on an aspiration that something's going to happen somewhere else if we don't really believe that's going to be delivered. We need to build our plans on what we think a reasonable assumption of where the rest of the system will be, and then aspire to make it better than that. So we're sitting looking at plans that have fallen off because of things that happen elsewhere, in part, and maybe we always knew those weren't going to happen, and separating our aspirational demands from our from reality is part of what we need to do better, slightly better forward, I think. Okay, thank you for that. Thanks, Jazz and Jonathan, for that. Some of these topics are going to come up frequently. It's nice when we start to narrow down the big issues to a handful, isn't it? Let me move on to my report, which you have in writing, but I think I should do the, let me kick off by just going through the births, deaths and marriages section of my report. So first of all, delighted to formally welcome Dame Helen Stevenson to our board, who is joining as Chair of the Quality Committee at Imperial and sitting on the People and the Finance and Performance Committees at Chelsea and Westminster. Helen has recently retired as the Chief Executive of the Charities Commission in England and Wales, and we are delighted to have your expertise. So welcome, and I hope you have a good time working with the renegades around the table. Thank you. As I said at the last board in common, Steve Gill, I'm going to start calling Sir Steve Gill because if it doesn't happen, it definitely ought to. Steve is stepping down as the Vice Chair of Chelsea Westminster after 7 years on the board, I think, and a period as the interim chair before the collaborative came together, and then as an absolutely fantastic vice chair and support to me as the chair. And I'm genuinely grateful for the help and guidance that Steve has given me over the last couple of years. Steve contributed a huge amount to Chelsea and Westminster and his support to Leslie, but also has stepped across and has been a NED at Hillingdon for the last couple of years as well, where he's brought his usual forensic analysis to bear on that as well, and they felt on occasion. So, Steve, I hope you enjoy your retirement. I find it hard to believe that you're not going to be sent out and told to find something else to do in a few months' time. But
my wife has lots of plans for me, and I think she'll send me out after a little while. She'll otherwise I'll drive her crazy.
Yeah, but on behalf of the board, thank you. Thank you. We have we also have another vacancy for a non-executive position, which will be the chair of the Finance Committee at Chelsea and Westminster, which we are interviewing for next week. So hopefully, come to the next board meeting, we will have another new colleague. And then we've either misplaced or in the process of misplacing 2 finance directors as well. So as I flagged at my last July meeting, John Bell, who was the CFO at Hillingdon Hospital, has retired, and Tracy Cottrell has joined us as the interim CFO. And Jonathan Reed, who we heard so eloquently from earlier, and well, I'm no doubt continue to hear from all the way through this meeting, is abandoning us and going to Brighton instead, my hometown, but I still don't understand why you would want to go there, Steve. Jonathan. So yeah, Jonathan's done a fantastic job at London North West and has helped bring it to a much more stable position with some really progressive plans about where the trust's going in the future. And so I am really grateful for the leadership role you've played, Jonathan, and I've no doubt you will have just as much fun when you get to the seaside to do that. We've brought in Don Richards as our interim CFO and are doing the handover at the moment. So we've got a couple running at the moment. So thank you, Jonathan. And last point I should make is that across the 4 trusts, we have now appointed a single chief information officer across the acute provider collaborative, So congratulations to Robbie Klein, who was previously doing that job across London North West and Hillingdon. And my thanks to Kevin Jarrold, who has stepped down and retired as the Chief Information Officer for Chelsea and Westminster and Imperial, who I first met in the NHS, I think about 15 years ago when he was at London Region. So Kevin and I have worked together for a long time, and he is one of the outstanding CIOs in the NHS of his generation, and will be a big loss to us. But I think we're very lucky to have Robbie to step up. So my thanks to Kevin. So wanted to just cover that. The other thing I just wanted to mention, and I'm sure Patricia will mention this as well, but I just want to share my thoughts. We have colleagues from CQC here joining us in the room, and we have Hillingdon Hospital has had 3 CQC inspections over the last 3 months, because joy really does come in bundles of 3. So one for the Hillingdon site, one for the Mount Vernon site, and a well-led inspection, which is just coming to a conclusion as we speak. And that's an enormous amount of work on the organisation. So I just want to share my thanks with the leadership team there, and particularly for Vikas Sharma, the Trust Secretary, and Lee Franklin, the Assistant Trust Secretary, who've done enormous amounts of work in facilitating that, pulling together the information that's necessary, and making sure that goes around, and make sure the right people are in the right time. I'll let Patricia speak more about that, but the rest of my report you can read. Thank you. And I shall move us on now, as it's still with me, to the board in common meeting, which you have the notes from here. We covered a number of issues. I think the 3 most significant ones, which were picked up in items 8, 9, and 10 here. One is we considered and agreed a paper from the 4 chief executives to create a shared leadership model across Chelsea and Westminster and Hillingdon Hospital, which has now been to the Trust Standing Committees, and will be coming back to this board later on. We had a long conversation about the Elective Orthopaedic Centre, which is doing fabulously well on patient satisfaction, and fabulously well on the quality of outcome, but we are not hitting the numbers of throughput that we have planned, and that's creating pressure. So we had a conversation about how we up the throughput on the Elective Orthopaedic Centre, and then we had, as you would have imagined from the conversation we just had, we've been having already a lengthy conversation about the financial position and the recovery plan. So that is for noting by the board as well. And on that, I'm going to move across into the quality and performance report, and first quality, and I'll turn to Pippa.
Thank you. So I won't go through every slide in detail, but on high level, you can see actually our patient experience across the 4-star fares really well, with some improvement areas. And same for our complaints and the way we're managing our complaints. We've just had in our APC quality committee the annual review of themes of complaints, and more importantly, how we learn and how we make improvements from them. You'll see our rates of infection control, nothing out of sync from what we're seeing nationally, but lots of scrutiny and lots of work in all of our trusts, and that's happening locally at the local quality committees, as well as the APC quality committee. VT risk assessments, positive picture actually, and we've got good compliance. Cerner has really helped us there with recording, and the VT risk assessments that we've now got the visibility of, and excellent mortality results, with all 4 of us lower mortality outcome than the national picture, which is absolutely fantastic. Maternity is a positive picture for maternity. So the stillbirth rate is below the national average, which is fantastic. You'll see for the first time we've broken the stillbirth rate down separate to fetal losses, because that's part of the national picture now, and improving experience of women with early fetal losses. The one indicator that has peaked in month is the intrapartum brain injury, where we've had 4 cases at Chelsea and Westminster. What I would say from them is we are a regional cooling unit, and we do proactively cool babies because we've got the ability to do that. This does not mean that all of them babies being cooled result in having a brain injury. In fact, the majority don't. So we are preventatively cooling them as a positive treatment. Every single one of them cases has a full PSSI, and we review them, and we're doing a thematic review of them to see if there's any additional learning. But otherwise, from a maternity picture, all is very positive, as does the maternity experience data as well. So that's it from quality. I'll hand over to you.
Thank you. And I should just note before we move on, there's a new performance summary for people on the front page of this, which is a real breakthrough because I understand it. So, the matching of red and green and the direction of arrows makes it interpretable to me. So, Patricia, thank you for that. Let me move on to access.
Thank you. So I'll just hand it straight over to Claire and Booth, actually, if that's all right. Thank you very much.
Thanks. So I shall start with urgent and emergency care, recognising we've already said quite a lot about it under the winter section. So in terms of our ambulance handover weights, we continue to have the best ambulance handover weights in London. You'll notice we've changed the metric in the report from the 30-minute standard, which we do very well on, to the 15-minute standard. And you can see from that we've got some work to do to get those extra few minutes off so that we can hand our ambulances over as quickly as possible. And that continues to be a work in progress and a big focus for all of us. We've talked about 4-hour waits in the emergency departments. There is some variation across the different EDs, but collectively we meet the 78% standard, and we continue to learn from each other and work on improving those pathways. We have a lot of work to do about our very long waits in the emergency department. So some of that, as we've talked about, is to do with mental health. The remainder is to do with patients who need admission into our hospitals and delays at the discharge end of our hospitals, making sure that we are able to free up the capacity that we need to keep flow going. So SDEC and all of the other things that we talked about helped with that, as does our focus on discharge and making sure we get our community pathways out of the hospital working as quickly as we can do. So I think they're the headlines from a UEC perspective, and I'm going to hand to Tina, who's going to talk us through elective care.
I'll just say one thing, because so just so everybody, so the absolute handover stuff nationally is 45 minutes. So we are really, it goes back, I can't remember who asked the question that says, should we set ourselves some challenging targets? That is what we're trying to do in terms of taking ours down to the 15 minutes. So it does expose us in terms of we won't be meeting it, but it does say that we're trying really hard to improve all the time. Thank you.
Tina Benson at Hillingdon and lead for elective care and diagnostics. So just to say, we are still remaining really well nationally and across London, despite we have more breaches than we would have liked. So the board will remember the target was to have 0 breaches of 65 weeks by the end of September. So obviously this is August data, but just to update the board, we did have a quite high number of breaches. We're just waiting for the final ones to be validated, but about 860. That's largely driven through London North West and Imperial. The trusts are having weekly meetings with the coup and in some cases the chief executives to drive the improved performance. We're also working with the regional London team because we all have challenges, particularly around ENT. It's a big risk for all of us, and asking if there's any other organisations across London. So not only doing mutual aid within the APC, but also seeing if there's any organisations who have some capacity across London so that our patients can be treated more quickly. We continue to do mutual aid where we can, particularly more recently picking up dermatology and general surgery coming over to Hillingdon. So we will see the Hillingdon breaches go up a little bit because we're making sure that all our patients are getting good service, which means that we will move patients and see those 65-week breaches move. The area of concerns remains diagnostics, where, or despite everybody's recovery trajectories, we're not seeing that significantly move. However, as we know, Ealing CDC is ramping up capacity, and that will particularly help us with MRI across the APC. So I will pause there.
Okay, so can I take some questions on quality and access there? If people have any points or questions that they want to raise before we go on to the workforce part of the discussion. Yeah, Linda, please.
Just in terms of, sorry, I didn't say who I was before, did I? Linda Burke, non-exec director for Hillingdon Imperial. Just in terms of IPC, we alluded to it earlier, but I mean, obviously the impact of that in terms of potential length of stay, etc. And having our quality committee, there was a big thing around catheter care actually, and again, people coming in and out. So my question is really, what more we could be doing as trusts, as a collaborative and with the community in terms of actually really trying to make some impact on that, because a lot of work's been taking place, but it doesn't seem to be having the traction that we'd hoped for.
Yeah, so we've done well, local quality committees are really owning their IPC agenda, right place to own it. We then have the extra layer of scrutiny at the APC quality committee as well. And we had a long conversation about infection control there. There are many campaigns, the national campaign of when it is appropriate to wear gloves, when it's not appropriate to wear gloves. The culture of IPC is really difficult in the NHS right now when we come out of COVID and we expected everyone to cover every part of their body up, and actually it's now the opposite to that, and we need to go back to right. So we've all got the right campaigns going, we've got the consistency across. The work we actually now need to do is more within the community. Most of our infection control that's coming in is community acquired. So it is the work around antibiotic stewardship in the community setting. We've got a really good grip of that in acute settings actually, and we've got very good visibility of it across all of our trusts, but we've not got that same visibility in a community setting. So it's the antibiotic usage in communities. It is the preventative community IPC that we then have to deal with in an acute setting, and of course that does take longer to change practice.
Thank you. James.
Thank you. James Walters, Chief Operating Officer at London North West. I just wanted to give you a reflection of where we are in terms of our cancer performance out of the 42 national ICBs. So North West London is currently 20th of 42 on faster diagnostic standard. We're 7th of 42 for 31-day decision to treatment standard, and we're 4th of 42 on the 62-day actual treatment standard. So I think being in the middle or the top 10 of each of the cancer key performance metrics shows a significant continued improvement over the last few years, both as a collaborative and working, of course, in partnership with RM Partners, our Cancer Alliance, where each trust has clearly identified improvement plans for the challenges that we have got that are contained within the paper. We try to work as a collaborative and support one another with our expertise borne out through the North West London partnership that we have. But I wanted to give you all a reflection of where we are nationally on our cancer metrics. Thank you.
Thanks, James. Yeah, AJ.
Thank you, Chair. Yeah, James, can I just pick up on that particular point? And it's about the referral to cancer treatment pathways in the 62 standard, 60-day standard. I noticed that we are, I think, -9% on the target collectively. And the sad person that I am, I looked at the previous 2 or 3 quarters, and you know, we're not really shifting that from Hillingdon. And I think Hillingdon, the data we had in early on in the year, the February data was 38% variation. In May it was 24% variation, and in July it was 16%, whereas the other trusts are down a little bit. So it just made me wonder about what's happening at Hillingdon. That's with other trusts, it's not particularly going in leaps and bounds in that way.
Well, I'll start, and then shall I invite you to come in, Tina? But I take some confidence that all trusts in the July data have achieved the 31-day decision to treat standard. So the plans are made, the patient's diagnosed, they're aware of those treatment plans. It is often purely our capacity to provide that treatment within the further 31 days to achieve the 62-day standard that is challenging us at the moment. But as you can see, we are 4th of 42 ICBs, so this is a shared challenge to regain much better performance in this area. Tina, do you want to add to that?
Yeah, so I suppose if those, I mean, the figures that you just rightly quoted, if you look at where the other organisations were, they were nowhere near as low as Hillingdon. So I would say it's easier to move to a higher position when you have a low baseline, and then the last piece towards the target becomes the really tricky piece, because they tend to be the intertrust delays and things outside some of our control, like where we refer to the Royal Marsden, for example. And actually, I would say that our Hillingdon pathways, we have a lot of interaction with Imperial. So it's us and Imperial that have improved the Hillingdon position. It's not just Hillingdon on its own. But I think when you move from a low baseline, it's easier to get there. And now Hillingdon, I suspect, will also slow down in its recovery, because you have to treat the backlog before you start to see that target improve.
That makes sense. And I think when I looked at the recovery plan and improvement narrative, it was really copy and paste from the last. So I wasn't quite sure what was shifting and what wasn't shifting. That's helpful. Thank you.
Benita, then Steve, then Carolyn.
I just also want to thank you for the clarity of the paper. It's really helpful, but I didn't look at the last 3 sets of reports, so I haven't seen the plans, but I think that would be very useful to have that information. So thank you, Jay, for pointing that out. My question was in a similar vein to Jay, which was the discrepancy at London North West on access to cancer care, which is sort of different from target significantly, and others aren't. So I just wondered, what's the real-time process that we have when one of our trusts is out of kilter on any of the diagnostics, or are we sort of saying, this is the data that we've received this quarter, we need to put our efforts there? I just want to understand that process, because it's great to see the aggregate data, but we have individual trusts that we have responsibilities for. So I just want to understand that.
James, you want to talk about the -12?
Yes, absolutely. Thank you. And London North West is moving up and down considerably on this measure. Sometimes we achieve, and this month, July, we haven't clearly. We've identified the cause of those challenges around the faster diagnostic standard, particularly in lower GI and skin. We've put additional resource supported by RM Partners, our Cancer Alliance, into the straight to test process in lower GI. That is starting to correct our 2-week wait measure. So we look right at the early stages of the process and how we can improve there, which means that the ability to give the patient a diagnosis much more quickly is helped by that early intervention. So straight to test is certainly something that is building momentum now within our division that looks after the lower GI measure, and we've improved capacity in skin and begun a small amount of outsourcing. In terms of the collaborative, we discuss other providers' experience and learning from their own corrective action. Often our RMP bring a unique set of expertise in how to turn around pathways that are struggling, and early intervention is often not quick enough to turn the performance in month. But we are on with plans in both skin and lower GI to improve that measure over the coming weeks and months.
Thank you. I'll take 2 more points. Steve?
Yeah, so my first question was about the 28 FDS at London North West. The second one was just coming back to the 62-day standard. If we're 4th in the country and we don't have any of our trusts meeting the target, I guess there's a concern here, isn't there, that as to first of all, there's clearly concern about the national performance, but at what point do we feel that we are able to get to the 85% target? Because we're fairly, despite the progress in Hillingdon, we're up to 69%. So we've got no one really consistently hitting this metric. So is there something specific that we ought to be doing differently?
Thank you. As Tina said, clearing the backlog, the percentage of achievement often worsens, but as we clear the 62-day patients, we do make progress with the percentage of patients treated within 62 days. And I suppose I can, each stage of the pathway, you heard me talk about focusing on the 2-week wait to identify very early. The faster diagnostic standard, absolutely crucial in those early stages. Achievement by all trusts of the 31-day starts to pave the way to achievement of the 62. Now, I wouldn't commit to a 1 month or 2 month improvement here, but certainly it's something that we hope to be in a better position by the year end with that continued work to optimise the front end of the cancer pathway. So I think year end is a realistic trajectory, Steve.
Thank you. Claire, did you want to say something on that before I come to Caroline?
Yeah, just to note very briefly, so the national standard is 70%. The 85% is a North West London and RMP commitment that to improve our cancer performance by the end of the year. So we probably need to make that clearer in the slide. So we're not where we want to be. We definitely need to improve. But in terms of the national cancer standards, we are, as James said, we're not doing too badly.
I didn't know that. Thank you. There you go. Carolyn.
So probably similar as a theme to what other colleagues have said. I thought the summary, the performance summary and the notes by theme was good. Thank you. It certainly made it an easier read. But I kind of think we do a lot of this to death, if I can put it in those terms, because we do it through our individual committees, and then we do it at our trust standing committee as an integrated performance report, and then we do it here as well. And that might be a good thing. I'm not saying whether it's a good thing or a bad thing, but I think what would be really helpful is some of the things that James is talking about that the execs are doing is to understand that a bit better. So who's really outperforming on some of these areas? Which trust is that? What can we all learn from that? Because as non-execs, we don't know. As execs, you probably do. But I think that would be really helpful for us to really concentrate on the areas where we can do better.
I was sitting here thinking something linked to that, which in our theme of what's the best we're doing in North West London, what's the best that's going on in the country, we ought to be exploring where we have better practice within North West London and what we have to do to adopt it, and where's cracked it, and if they've cracked it in Northumbria, what do they do that's different?
So I agree with that, and we can do that. So I think, and we should have said about the I think we've got used to it, and so forget. I think the other bit is that, and it goes back to what do we bring here by exception. It is important that this is our only public meeting.
Yes, that's true.
So I think there is something that says what are the things that we really do think we're doing well, and what are the things that we need to acknowledge in public that we do better. But I think actually for the learning for the organisations as a whole, that bit, particularly for our non-execs, that does bring, actually these are the things we're doing either to address something or to share all those things we will do better. And I was about to say about the EMB, you might want to.
No, then I'll move some.
Yes, I mean, I think it's a really good question, but it's actually probably a slightly more complex question than it is at the site, because the trusts are very different in terms of both scale and in terms of population and in terms of, and in some cases, treatment pathways. So I think there is in some respects, we as a group need to understand what those differences are, and therefore where you absolutely can draw learning from one to another, where actually differences in the case mix don't. And we can think. I mean, as I did say, actually, what we do is to think about a lot of this at the collaborative EMB, and we can probably use the report from the EMB to perhaps pull out some of those themes more obviously for this meeting. But I completely agree with Les. This is our only public board meeting, so it is.
This is the match of the day versus going to all the games.
The highlights.
So just a couple of things in relation to that. So the board will recognise that we have changed the report a bit for this month, because we said we would move, first of all, to more of a real-time report,
And secondly, the ability to drill down at different levels. So as we develop the next iteration of this report, we'll be in a position where you'll be able to look at the report by site. Now, probably not at this meeting, but certainly at the collaborative committee level, we can do that. The intention is that we will move over time to having standardised reports at trust level, so that you can, it wouldn't matter which committee you sit on or which trust you're in, you'll be able to see similar reports, recognising, for instance, that we wouldn't necessarily look at, say, sickle cell patients at Hillingdon, because that's not a treatment pathway we'll follow, but Pat and Tim would want to see reports on patients with sickle cell disease. So recognising the differences. The other thing, just picking up on Tim's comments, we do, rightly so, I think, for the APC, compare the 4 trusts, but actually, if you were comparing us to the national positions, we wouldn't be comparator trusts for the national positions, because you'll look at what they tend to do at a national level is look at comparator trusts in terms of sex mix, demographics, or whatever. So we do get sometimes a slightly different position because we look at the APC, but I still think it's been phenomenally helpful to look at the 4 trusts and compare and contrast, because I think it has driven changes in our practice, and that's one of the advantages.
I'm going to move us on because we need to just a little bit. Let's move on to the workforce report.
I'll just say really quickly. So actually a very positive picture. So we've in terms of our vacancy rates, in terms of lower than target for our voluntary turnover rate, and agency spend for the trust is within the national target, and Hillingdon are doing some work to identify what's driving theirs. The work that we're now doing is around appraisals. We are implementing a single learning platform across the 4 organisations, which will mean we're recording the same way, which will help this dramatically, because there are some recording issues. The last thing I'll just pinpoint to this is the model employer goals. So you've got our equity work that we're doing there around the national target by August 25 to have met the model employer goals. We know they're very ambitious. You can see broken down by trust. We actually do well in the 8s, in the band 8s, and then it drops off as you go into the 9s, VSNs, and that's the work we're really focusing on, and the work we're doing collectively to be more in terms of career progression and recruitment.
Thank you. Any questions? Please.
Well, just kind of being benefiting and seeing lots of other organisations, just to congratulate you really on certainly on your sickness rates and your vacancy rates, given the challenges facing that you're facing. I think they're very positive. I've seen a lot worse in other places.
Yeah, and I would say this is where the APC is delivered benefits. So the collective recruitment we've done for our hard to recruit to posts has really started to pay benefit. We'll probably have one of the lowest midwifery vacancy rates once they all come into post, and that's because we've done collective recruitment as a system, as an agency. So that we've done the same. Lindsay's leading some work that we're doing now around our AHPs and some of the occupational therapy and the other roles. So it really means you can recruit differently and more dynamically, which is starting to pay benefit here.
Thank you. David.
Thank you. So like everybody else, I think it's really improved report. Thank you. A couple of things I would just say, well, I'm curious about. Under assurance, we have a few exclamation marks. Does that mean we don't have assurance? We're waiting for assurance? I'm curious what that means. And the second part of my question is, given that some of these targets are self-inflicted harder targets, which is a good thing to do, I think we should put in a column to say where that is to avoid confusion. And it also helps us stretch even further. Just the first point really I'm curious about. Thank you.
So this was, we will find this, but this was to try and give the board a slightly different visual way of understanding where we mean statistically significantly different. So where you don't have up or down arrows or you don't have exclamation marks, it's because there isn't a statistically significant change. The exclamation marks are essentially saying we don't believe we'll meet the target at year end. And in that situation, for instance, if I take healthcare associated infections, because of the way the targets are set nationally, we know in a number of trusts we've already breached the position, and therefore we don't believe we'll get to them here.
So we've got assurance on the figure, but not assurance that we're going to achieve the result. Thank you very much.
Great, thank you. Thank you very much. I'm going to Oh, sorry, sorry, Simon.
Yeah, just one quick question. Like everyone, welcome, especially on discharge. What would be really good to see the data, but what would be helpful for me is the percentage of beds that is of total beds. I don't know. So we've got 551 beds across the APC that are people that are residing there. What percentage of that is that of our total bed number?
Yeah, at any one time it's about for no criteria reside, it's about 14-15% over the IPC. Sorry, what am I talking about? I see, I don't know where I am. Sorry.
That's a single transferable answer that you give it to journalists.
No matter which ones I mentioned, all of them.
Thank you.
Started with And I'm sorry, can I just say, and Leslie, I haven't had a chance to pick this up with you, but I did have a comment which hasn't gone into this about whether or not we should be setting a target for discharges. I think actually it might have come from you, Matthew, about it doesn't actually say in here what our percentage or what position we should be in. We need to probably have. Okay, thank you. So what we should set as percentage, and we can probably agree that at EMB is percentage of public zeros, ones, twos and threes should be, because we do know what those should be. So we can.
I think it dates back to the previous conversation about when we set our business plan at the beginning of the year. If we're assuming 10% of our beds will be occupied by patients who ought to have been discharged, and we're now at 14, we know that there's a 4% variance. So that actually, what was the planning assumption for some of these things that we came into the year with? And then what's the plan to get us to there in order that we can make it through? Because 0 is never a good number for delayed discharges.
Thank you. We'll take that away. I mean, we'll have to agree that with the ICB, because that is certainly not.
It might help force that conversation, yeah. Thank you very much. Okay, I'm going to move us on to the committee reports, and I'm going to aim, by the time I've gone through these, to have got us back near the time, so that I'm not squeezing the finance conversation later on. Steve, the Collaborative Quality Committee Chair's report.
Okay, so in the interest of trying to get us back on to time, I'll probably make 3 or 4 points. The first one was around infection prevention control, which we covered in some detail at the committee. That was referenced the fact that we are assured, despite the fact that we're tracking above the recently thresholds, that the majority of the cases are now community-based, and we have the right controls in place internally. The second one that I was going to mention was mental health, but we talked about that at some length, so I don't think we need to cover that anymore. And the third one was around the work being done on EDI, where the task and finish group is now, it's a 6-month task and finish group, which I think is really going to help us have a much better understanding and analysis of what's going on within our quality metrics. And that's probably all I would say. And as an introduction to the things that are coming next, back to Carolyn's point, the next 2 items, learning from deaths and the complaints report, been reviewed in detail at the individual quality committees. They've been reviewed in detail at the collaborative quality committee, and they're here for noting. I don't think that we necessarily need to go through them in excruciating detail, which may help me get back on track. And I'll stop at that point.
Thank you. Very good. That report is for noting. I'm going to turn now to the learning from death report, which we should do with exactly the right amount of detail. Thank you.
I'm going to say 4 things about it. First of all, I'd like to report that all trusts' mortality review processes remain extremely robust, and they give us very good opportunity to look for opportunities to improve care, and they are functioning very well. And that is one of the reasons why the report is so clear and straightforward. So thank you to everyone who's involved in that. The headline is that our HSMR and our SHIMI across the acute provider collaborative in every case is below the index point, and entirely below as expected for HSMR, 3 out of 4 below as expected in the SHIMI, and Hillingdon's is below the index point, but it forms statistically within the expected range. But that's an incredibly reassuring position to be in terms of the quality and safety of care that we provide as an acute provider collaborative.
I think we should, yeah, thank you for making that point. I think it is important. And another board that I spoke to about the thing about trying to bring together a collaborative had gone through our board papers and said, oh, you still look at SHME and HSMR data at your board. I think we ought to start doing that again as well. So it seems to me to be one of the critical metrics for quality. So
thank you. Third point is that we've got regular thematic reviews that are undertaken either at trust level or at collaborative level. And we also dig into diagnostic groups. There are no new themes to escalate to the board from those, but those are robust processes. And lastly, I want to note the medical examiner process, which is robustly carried out throughout the sector. And our medical examiners have taken on the statutory responsibility for scrutinising all deaths within the sector, including non-hospital deaths, since the 9th of September, and they are doing that with great rigour and great thoroughness, which will improve learning around deaths outside our care, as well as the deaths that we look at in great detail within our care.
Very good, thank you. Any questions for Roger? Yes.
Yeah, I wonder if you can ask a question around the work of the medical examiner. I get a lot of complaints and referrals from religious organizations who need to bury within 24 hours. And it seems to me that there's a hiccup here, Roger, and I'm not sure what it is.
You're right that there are significant concerns around different faith groups where there are urgent referrals, and that process is something that has been established across 7 days. We know that it needs to be improved, and there's work going on not just from our own medical examiners, but across the medical examiner community, both regionally and nationally, to try and improve on that. I'm confident that we are getting to the right place on that, and indeed we are. Already, you can see in some of the report details that we are addressing this proactively. But absolutely, Aman, we recognise that that's a real challenge and something that we do need to have addressed.
Thank you, Jen.
Yeah, just to add, Amanda, that I've set up a regular meeting with the Garden of Peace, who oversee most of the Muslim burials, and they've got our mobile numbers certainly to ring if there are any problems. I mean, we seem to have resolved them at Imperial, but I do sometimes ask if there are any problems across the APC, because I'm more than happy as I meet to take issues and then feed them back into the other trusts. So I'll pick that up next time. I think we've got a meeting in a few weeks' time again, so I'm happy to pick that up again, so that we're meeting the local community's needs, not only with Muslim burials, but across some of the other faith groups that like to bury their deceased quickly.
Thank you, Janice, that's helpful.
What's the time scales?
Sorry.
What are the time scales? And Jewish people?
Ideally, it's within 24 hours,
24 hours.
And we are responding to that, and we are putting the process in place. I would say we largely do manage to achieve that, but we know that we're going to do getting there.
Okay, thank you. Thank you very much. Okay, can I move on to the complaints report? Lisa.
Yes, thank you. Lisa Knight, Chief Nurse, London North West. Firstly, just to state that each individual trust has presented its own statutory complaints reports to their own quality and safety committees and to their trust standing committees, and each have completed their governance cycle for the year. This paper is an amalgamated position of our complaints processes, which was presented to the APC Quality and Safety Committee earlier in the month. So we have a working group chaired by Michelle Dixon, who is the Director of Patient Experience from Imperial. And the work that this group has been doing is primarily to align and improve the reporting processes across the APC, looking at complaints processes, reporting processes, and I think most importantly, looking at the themes of complaints and trying to learn from each other on the ground about how to make things better for our patients.
Just to note that from an assurance perspective, all of our trusts have the fundamentals of practice in place, such as in-date policies, reporting structures, and executive leads. So the working group has found that whilst the trusts are applying the national guidance is actually very high level and actually quite difficult to apply in practice and to provide standardised reporting. So, for example, if we look at the report, I'm sure you would have noticed that, you know, there is a discrepancy between what organisations have upheld, and then London North West partially upheld lots of complaints, but hardly upholds any fully. So we're trying to work through how you apply those criteria in practice. And this is just evidence of where we haven't managed to do that yet, but that's what the working group are working on. And I think, you know, another good example of that is the complaint themes. So how do you categorize a complaint when the categories are communications and values and behaviours? You can see it's actually quite easy that, you know, from a on the ground perspective, you might put something into a different category, even though it might say the same thing. So that's the sort of criteria that they are working on and trying to work that through. I think just a few other points. They're doing a piece of work looking to apply the demographic and equity data to our complaints, and that will come back throughout the year. And I think that the committee, you know, we're particularly keen to let the board know that their particular work about themes and sharing improvement methodologies and improving patient care was the heart of what they were doing. And I think that's all I wanted to say, Chair. Thank you.
Great, thank you. Steve, then David.
One of the other things that we talked about at the collaborative committee is that we've got a higher rate of complaints, relatively speaking, per 1,000 WTE at both Hillingdon and London North West. You want to, would you or one of your colleagues like to just briefly comment on the discussion that we had on that?
Yeah, so we had a discussion about you know, what we've got on the ground as well. So, for example, we've looked into this extensively at London North West, and we have a very large we have a substantial complaints team, but we don't have a substantial patient advocacy service. So what we're looking to do is convert with that, which I think Chelsea and Westminster have been very successful in, which is trying to put early resolution on the ground before it becomes a complaint, which is obviously a much better outcome for the patient, rather than waiting till a complaint happens and not resolving it. So we're looking across the patch to align those in a different way and be more proactive in preventing complaints.
Very helpful. Thank you, David.
Yeah, thank you. So this is, of course, extremely rich feedback from patients or their families, and we should also assume it's tenfold that don't actually complain. But there's a lot of feedback that we can use, and if we weren't the NHS and we were a competitive business, it would be a problem because people would go elsewhere. And of course, in our case, they can't go elsewhere. But the learning that we could pick up externally could be invaluable to improve that patient experience. So I just ask if we could perhaps have somebody external to the NHS give us some hints on how to improve. Thank you.
Thank you.
Just a simple one, really. Explain to me how this rate per 1,000 WTE is worked out.
Yeah.
Do you want to do it? So there is no national rate. So there is no standardised way of measuring complaints. Actually, and that's fine if you're an organisation and you don't want to benchmark. We obviously want to benchmark because that's the idea of the collaborative, and that's the idea of looking what best practice looks like. So we worked with this was the metric we used in all transparency. It's about to change. It's about to change to bed days because it's probably a more reliable, although even that has some flaws because bed days only looks at the patients. You might have complaints from your outpatient service. So there is no national standard is what I was saying. We're playing around with what is the right one. So what is this? This is the number of whole-time equivalent staff that you have in post. So the number of
by staff, so it's by measure of the size.
The measure of the size of the organisation.
And if all the metrics give you the same point, then we need to not worry. It suddenly changes if you do.
I think the fact we use bed days for everything else just makes it consistent.
We did have exactly the same discussion as to whether this was a really appropriate or helpful metric. And I think the view was that it was probably the best we had, but wasn't necessarily all that helpful.
Spinning because I thought whole-time equivalent staff. I thought this was
Yeah,
about-
yes.
so-
Exactly.
Thank you. 4 points. First AJ, then Helen.
Thank you, Steve. Yeah, just on the point of demographics, can we make sure that we look at accessibility to our complaints procedures as well as learning from, so we get sort of, we get themes from obviously we look at the protected characteristics. It's also about communication, accessibility, just so that the learning, because I think, we will get the themes, I think, will be similar across the trust. So there will be some rich data there across the board in terms of what we actually do with the learning.
We actually already have that data. It's one of the questions in the patient survey, which is, did you have the ability to complain and give feedback? So we do have some headline data on that.
Thank you.
Yeah, I think I agree on metrics. I wouldn't worry too much. It's about something that we can benchmark against each other. I suppose the real richness of this is, what is it telling us as a collaborative? And the complaint themes are quite high level, and I'd just be interested in your experience. Is that throwing up kind of more kind of detailed areas that's enabling you to think about and change practice as a result? Because it's that that's the real value to this data.
Yeah, I mean, absolutely. There's one part of this is the governance. Are we responding to complaints in an appropriate time frame that are an appropriate response? That's a small part. The biggest part is, what can we learn? How can we use it to improve practice? And how can we triangulate this with our learning from incidents and our legal claims to put an even fuller picture together? But yes, the biggest themes in here is communication. It's not just communication whilst in hospital. That is a big theme from it, but it's also communication in terms of outpatient appointments and things like that. So they're the quickest wins, I think, that we could do to communicate better and fuller and in different ways to our patients. There isn't one type of communication that suits all patients, so we need to do that
I'm
differently.
going to wrap this up, otherwise we're going to go on. I think it needs to go back to the quality committees. Did you want to say a final word?
Well, just on that, I mean, the reason this has come is because it's a sort of a statutory requirement to report complaints. But as well as this, we have patient experience surveys, multiple national ones, and we have our friends and family tests. So this is only one way we get patient feedback, and we have significant other ways of looking at patient experience, and those are obviously discussed at the patient experience committees locally and in the local quality and safety committees as well.
Thank you. I'm going to move us on to the people committee, David.
Great, thank you, Chair. So there's so much to cover, isn't there? So I just want to say two things. So there's two takeaways from our people committee. One is that the level of violence and aggression on our staff is concerning. Some of our trusts are doing more than others to help about that, but that's a flag. It's increasing and we're worried about it. The other one is that we've still got concerns about the number of WTEs, FTEs, staff numbers versus our budget. So you can read as much as like, but those are the two takeaways. Thank you, Chair.
Thank you very much. Any questions? Please, Sim.
David, your second. I just want to ask whether we have a clarity about what we mean by productivity. You've heard this word used by national teams, and we're looking at sort of, how productive our staff are, how productive they were in 2019 and how productive they are now. Do we have a sense as an NPC what we exactly mean, a definition of productivity, and what we're exactly measuring? Because I'm not quite sure we have that, and I think that's something we need to do better.
So I have an answer, but I don't think I should give it.
Tim, go on.
So do we have a sophisticated answer? No, and we don't have that yet, I think, in the NHS. But do we look at the number of whole-time equivalents we have in post now versus what we had in post pre-COVID versus the level of activity that we're delivering in both an emergency and outpatient pathways? Yes, that's what the fundamental measure is telling us. There's 2 points to this. So one point is, first of all, we have to make sure we've measured all the activity, because if we have it or captured all the activity, because if we haven't, we've got staff that are delivering it and we're not showing it in terms of productivity, and there is a bit of that going on here. And then the second thing is we need to be more efficient, and we all agree to that, in that how we have definitely got too many staff in post. We're all signed up to that, and the way we have to manage our flux in terms of our use of agency and bank and agency is what we're working on to try and minimise that. Do we, any of us, think our staff are not working hard? That message is not the case. Our staff are working extremely hard, and then they are being very efficient in what they're doing. The system doesn't always allow them to be efficient.
You and I have talked about this a lot. Do you want to?
Yeah, I mean, just to say, so if I go back to our joint executive group a couple of weeks ago, so before we started the discussion about the efficiencies, we had a lengthy discussion about productivity. So I do not think we have a good comparative measure of productivity across the APC. And we asked the CFOs and the CPOs to go and try and do that, because it is complicated. And I think, again, the differences between the organisations in terms of number of patient-facing staff, people who are involved in direct patient care, and changes to the establishment over time, that we need to sort of bottom out. And we've not been, I think, proactive enough in taking our view of what our productivity is to other people. That is an important thing for us to do alongside the work we're doing around heading off on our efficiency programme.
Can I ask a very simple question, the Daily Mail question? Are we treating more or less patients than we did 3 years ago?
Much more.
I mean, that comes into it when we start talking about efficiency, about the message that we would want to get across to the public in a really simplistic way.
We could go on. It could open a real discussion.
I think what are the productivity metrics that we are going to use in order to benchmark ourselves going forwards is a topic for the F&P committee, and we need to land a set of metrics which we're using at this meeting, which tells us whether we are getting more or less productive in different areas, and it'll help as a different view on whether you have a deficit or not. Can I move a button, Linda?
Just a very quick point. I think it's really welcome how good the metrics are in terms of recruitment, etc. But there's a slightly worrying trend in terms of freedom to speak up and some of those cultural issues around, are we confident?
I'm about to come to the freedom to speak up.
Are you going to do that separately?
All right, freedom to speak up report.
You're getting ahead of him. He's trying to accelerate you.
Thank you, Chairman. Yes, Lindsay Stafford-Scott, Chief People Officer. Sorry, my voice might not hold throughout this report. So this is the annual 2023-24 Freedom to Speak Up report for the collaborative. As with other reports, just to note that the individual Freedom to Speak Up reports have been through the relevant local people and workforce committees, and this report has been through the collaborative people and workforce committee. To note that we've seen 221 concerns across the collaborative in the period, which is an increase on last year in general. It shouldn't necessarily be seen as a bad thing. We are seeking to encourage our staff to speak up and raise concerns. So we're not disappointed with that. The significant majority of concerns across the themes that are set by the National Guardian's Office are around wellbeing and worker safety, which of course we've just touched upon, around things like violence and aggression, but it also includes civility, respect, bullying and harassment across the workforce as well. And by way of assurance, that is a key priority for us in the Acute Provider Collaborative programme, looking at health and wellbeing and support for our staff. Each trust, in looking at freedom to speak up, has adopted the national policy and procedure and guidelines, and has voluntarily completed the national reflection and planning tool. So that allowed us all to assess where we were against the best practice guidelines. And each trust has now put in the necessary remedial actions if there was anything that was missing. That's led to improvements in all 4 trusts across promoting of the service, training more champions, and positively identification of some of the limitations of the data, for example, around themes, demographics, so that we can understand where the concerns really sit. We've agreed now to procure a new software system where we can all collate the same data and start reporting thematically, and we're just about to launch that in Chelsea as a pilot rollout. That will allow us to triangulate the data, and the trusts are all working with the other data that we get around complaints, around data, serious incidents, sickness data, internal ER data, to get a much broader picture around what is this telling us about the culture in our organisation and where do we need to target our efforts. And one of the areas that we've also identified is the additional support required for our overseas recruits. We're in the fortunate position of having the North West London International Medical Graduate Induction Hub, which allows us to access all of our new medical international recruits, and we've introduced Freedom to Speak Up in there alongside the international nurse induction programs as well. So significant work ongoing. Next year we'll be in a better position through that analysis to provide more demographic data But by way of assurance, there is significant work going into that civility, respect, violence and aggression piece of work across all 4 trusts. I'm happy to take any questions.
Thank you. So Linda.
So I think it's really pleasing, as I was saying, to see the work that's going on around the freedom to speak up function and how we're sharing the knowledge there. For me, the bigger piece is around the whole thing around managers training and the feedback and the culture that sits underneath that. So as we know, the freedom to speak up is just the tip of the iceberg in a sense. And what's the work that's going on across the collaborative as well as what's going on within individual trusts so that we're learning from best practice?
Absolutely. So under the Acute Provider Collaborative People Services Improvement Programme, there's probably 3 key work streams that contribute to that. So there's the health and wellbeing work stream, where we're all collaboratively working together to look at violence reduction, bullying and harassment, and how can we learn from what's gone well elsewhere and from good practice across the 4 trusts. There's also another programme looking at leadership development. And at the moment, we're looking at implementing a national programme, which is the Expectations of Line Manager programme, which is actually a really useful resource from the centre, but tailoring that so that it is meeting the needs of our trust, but is consistent across all 4. So all new managers will go through that, and newly promoted managers will go through that training. So there's a key focus on that as well. And then there's the Equality, Diversity and Inclusion Plan, which is looking at the differential experience of our staff from the global majority and getting underneath that and understanding what can we do to really tackle that head on and understand what's causing that difference and what can we do. One of the things we're looking at is there's been a couple of pilots within trusts of leading with cultural inclusivity training programs. We got some really positive feedback, so we're looking at how we can roll that out more widely. So it's been picked up in a number of areas, but consistently across all 4 trusts.
Thank you. Carolyn, did you want to comment?
Yeah, so it's not a dissimilar point, and I think you've referred to it anyway, Lindsay. So I've got no idea whether 12% at Hillingdon is good or 4% at Chelsea and Westminster is good from this report. And it might be that Hillingdon does masses of encouragement, or it's massively not great, but one or the other, and vice versa with Chelsea and Westminster. So until we get that heat map, we're not going to know, and we're not going to be able to intervene in the appropriate way. So the question really is, when is the heat map going to be ready?
So our aim at the moment is we're working on, we haven't got the data and the system rolled out across, so we won't have 12 months worth of data for freedom to speak up. We do have 12 months worth of data for the other data around ER casework, stigmas and so on. So we're working on that.
Grievances, presumably, disciplinary.
So by the end of this year, we'll be able to do that look back, get that baseline data that we can then start to use next year for targets and measuring ourselves.
And it's really a follow-on from that, in that we certainly know at Hillingdon that quite a lot of issues that are raised with the Guardian don't meet the true criteria for speaking up. And somehow or other, I think we've got to try and understand what I would regard as truly speaking issues where people have tried to escalate it through our existing systems and are getting nowhere, and they've got specific concerns about safety of patient care, as opposed to actually my manager's not very nice to me, which I hasten to add is also an issue and could well be affecting patient care. But I think it would be useful to see that breakdown as well when we're trying to map this out. So, because I think there's a lot of really rich data that comes through our Speaking Up Guardians, and I actually think we've got a really good system, but we could do to understand what it is we really need to tackle.
Go on.
Yeah, thank you. Just in response, Dawn Cliff, Director of Corporate Affairs, London North West. Just in response to Carolyn's question, Carolyn, the National Guardian's Office do publish data for all trusts who have a Freedom to Speak Up service. So we can certainly take a look at that data and try to do some comparisons in terms of counterpart organisations to see how we look. And we can certainly start including that in future reports.
Thank you. Thank you for the report. I do think it bears a bit of thought about what you do with this information, because as said, when we talk about report the incidents in Oz, we treat a higher number being reported as being a sign of good transparency. So I don't know whether a small number or a large number is good. And it could be either. It could be a sign of a really poor culture in an organisation, or it could be a sign of a really good culture in an organisation. So I think we probably need to think about what the hell we do with this data, other than knowing that we have a system. Okay, I'm going to take two more points, AJ and then Tim, and then I'm going to move on.
Thank you. Just very quickly, just on the point of triangulation, I think there's two sides to this, isn't it? So one is really what leads to somebody speaking up. So it is, pulling in harassment, or it could be attitude and that kind of thing that's mentioned in here. But there's the other side of it, which is what happens afterwards. So triangulating information about the number of leavers, while they're leaving, and is the data telling us, are the exit interviews telling us that? And also, I think it's also about accountability. So as a non-exec, I would naturally think, well, so what? So we have we have this in place, we have the learning, but actually what happens to, if somebody has bullied somebody, if somebody has had a bad attitude or whatever, and the complaint's been upheld, for example, what happens to those management practices, if you like? So I think there's triangulation on both sides. So it'll be interesting that when we look at the learning piece, it'd be great to have that within the report.
The last word.
Yeah, thanks, Matthew. So just to follow on your point. So the majority of the cases that come to the Freedom to Speak Up Guardians are not patient safety issues, which was the original purpose of the Freedom to Speak Up Guardians. However, they are an incredibly important mechanism for people to be able to speak up. And so whatever we do, we can't, you may argue that they should be able to go up through their line management. However, we need to encourage people to speak up in whatever way they are comfortable in doing. I think that's really important. I think we certainly have found in the past, we've put in a mechanism to try and help the guardians, because if they end up taking on responsibility for some quite difficult sort of HR cases if they're not careful. So making sure we've got the process for the guardians to hand off those cases to the right place in the trust is incredibly important. And it's really important that the guardians have access to anybody from the ward to the chief executive in order to be able to raise a concern. I think all that's important. It's probably worth, to your point, Matthew, us thinking about looking at the ones that genuinely are patient safety in one block, and then taking the ones that aren't and combining, as Carolyn says, with all of those other bits of data around the ER cases, all the other feedback about bullying, harassment, disciplinaries, and to triangulate to see what is our organisational culture like and where do we need to access it. So we can take that away and think about the ATC.
Thank you for that, Tim. Thank you. Thanks for the report. I'm going to move us on to Steve and the Collaborative Data and Digital Committee.
Okay, I'll take in the interest of time, I'll take the paper as read and just talk about the escalating points. So the first one is around cyber security and understanding the risks both internally and with our key suppliers, and the link from that through to our business continuity plans. The second one is around the need to establish our equality, diversity and inclusion metrics and accelerate the progress on that, so that we've got the right metrics in place to be able to do the analytics as we go into the planning process 25-26. And the third and last one is, as we were talking throughout this meeting, is that there's an enhanced need for data and analytics to be able to understand and drive improvements in performance and quality of care. And as the committee discussed the fact that to enable us to do that, we will need to put together a business case to ensure that we've got the appropriate funding in place. And I'll stop.
Thank you. Any questions or comments?
Can I just ask a question? So just to be slightly controversial now, is it the place of a committee to say we need to put a business case together to say, I can feel the heat of the room's gone on. So I guess my question is, first and foremost, are we clear that individual trusts don't have that? And second, is that not a thing that should go to the EMB that says, you know, you need to decide how you're going to do this?
Just so I obviously wasn't clear, that business case would go to the EMB. It wouldn't go to the Digital and Data Committee.
But there aren't individual digital and data committees, because otherwise the same people would have to go to all four. So the point at which the progress on the data strategy and the executives raise the fact that there's a funding issue comes up at that, and it of course goes back to the executive. And I don't think only in content would get approved off here, not in budget.
I think that's helpful.
Thank you. Any other?
Sorry, I was just going to add to that, Leslie, there is a very clear governance structure about how that digital and data strategy and any of the other digital programs are being developed. They come through EMB and would have to be, as we have already, come with where they're funded through local actions and where there might be an APC level discussion around that structure there already. This was the committee saying, make sure that happens, but there's absolutely a governance process for that.
Thank you. Just obviously slightly out of sync, but thank you.
Thank you very much. Moving on to Bob and the Estates Committee, State and Sustainability.
Thank you, Chair. I'll take the report as read. Things to highlight: work to standardise aspects of reporting across the 4 trusts improve, so we can start talking authoritatively about green planning and sustainability. That's good, so we can get some common reporting going. In the context, we anxiously and enthusiastically await the business case pipeline to come through, so we can test for strategic coherence with the aims of the collaborative. And just finally, there will be an ask coming back from the committee, trust standing committees, having now done some benchmarking about accessibility of estate, which is very good, but we do think it's appropriate for trust standing committees to feel comfortable about how their estate is appropriately accessible to their patients, rather than it being overseen by the collaborative committee. Having done it, we think there's something that locally people will want to keep their eye on, and I'll be writing to relevant vice chairs.
Thank you. Any questions for Bob? Very good. Thank you very much indeed. I shall move us on to the Finance and the Finance and Performance Committee. Carolyn.
Thank you, Chair. Very, very briefly, I think we'll discuss most of the issues under the finance report. So the only thing I really need to emphasise is the issue of income allocation. And I think that really needs significant scrutiny through every trust, actually, about the level of expenditure that we are actually putting in to delivering specifically commission services, and whether the income covers that or not. I think we've got to be very explicit about that going forward, and we really need to be in that position, and a position of strength, if we are going to challenge the ICP about those issues, and I personally think that's where we need to get to. So I'll leave it at that for now, and then I'm sure everything else will be covered in the finance discussion.
Very good. Are you happy for me to roll straight onto Jazz's introduction of the finance pack, and we'll roll questions in one? Yeah, Jazz.
Right, thank you very much, Chair. So the finance report sets out the financial position at the end of the month 5. At that point in time, as a consolidated APC position, we reported a deficit of 63.3 million. That's an actual deficit against a year-to-date deficit plan of 7.5, so 55.8 million after as to where we thought we were going to be. So a very challenged financial position at the end of month 5. The main drivers of that adverse variance, we're still having the industrial action costs. So that's basically the cost of backfilling for industrial action, as well as the income that we lost by standing down some activity. Although we have been notified now by the national team that funding has been made available to ICBs to be passed through organisations, so that should be mitigated out in terms of our recovery plans. I think it's fair to say that the efficiencies year to date have slowed down a little bit. So that is part of our problem about why we're adverse to plan. I think it was good to say at planning stage, though, we had very good plans about what we were going to pursue and the financial benefits that would arise from it. But we haven't managed to crystallise everything to the tune that we needed to do. That's a material part of our variance. And then obviously we've talked about the system optimization proposals, which I think based on a conversation we had, maybe we're a bit more aspirational around some of the benefits that we would get from that, which are not yet delivering. And each organisation is undertaking a business case review to make sure all the business cases that we have approved in year are actually delivering the benefits they should have done, or is there an opportunity now to really rethink some of those decisions and pull back some of that expenditure where it may be more beneficial financially without obviously impacting quality of care that we're trying to provide. So there's always that line to consider when we make those decisions. In terms of some of the operational stuff, absolutely, we've all got our winter beds open. The ICB had been clear that on the 31st of March, it would stop funding the capacity we had opened over the 23-24 winter phase, which we all felt was not sustainable. And we had some agreements about keeping that capacity open. But obviously, that comes at a cost. All of us have some 24-25 winter money within our envelopes, but that was supposed to be utilised in the latter half of the year. And I think it's fair to say in our organisation, for example, Imperial, we've already utilised that up front. And then the question will be, what do we do during winter 24-25? The national message very much is there is no new money for winter, and it's going to be for systems about how we manage that throughout that period. So that feels like quite a challenge, both operationally probably and financially, that we need to think about in our forecast. We have been trying to calibrate excess inflation, how much additional cost has come in because inflation rates are higher than the funding we receive. And to date, we've got about 3.3 identified as that. I would say that's a work in progress. And we're trying to get more intelligent information about gathering that across the APC in a more coherent and robust way. Good news on elective performance, we're obviously doing better. So there's a favourable variance of about 18.8 million across the collaborative. And there was a significant improvement in August across two organisations of 7 million, namely Chelsea and London North West. And I think all of us are obviously looking at our elective performance. How far can we push our productivity to make a contribution from that front as we talk about our recovery plans? In terms of capital, no major concerns. We're slightly behind by about £8 million year to date at the end of month 5, but all organisations are forecasting to cover their capital resource limit, which is a key performance target. Although the capital plans may be broader, there's donations and other aspects of funding in there. They don't score to the CRL, so it's important to make that distinction that the capital resource limit is a metric, and we're on plan to do that. In terms of cash, the combined cash balance at the end of August was about 262 million across the organisation. That shows a significant reduction since the end of the financial year and against a plan that we had set when we were submitting in April. And I think cash resilience remains actually a key area of concern across the collaborative about how do we stabilise the cash positions across the 4 organisations. Because I think there are a couple of organisations that are significantly challenged and probably likely or are seeking cash support in order to make sure they can deliver their financial operational commitments. We still have a financial performance escalation and recovery process in place, which you agreed in 23-24, which are the 4 organisations come together as a CFO group to check and challenge each other in terms of what they're showing and have we got the basics right, and what's our forecast saying, and what are we doing actually in terms of grip and control, elective work, income generation to try and stabilise our position so that remain in place. And then the report goes into a lot of detail around each of those areas by organisation. So I was going to pause there for now, Matthew, and then probably there'll be a broader conversation about the financial position.
Thank you. Very good. Very clear. Questions, comments, Bob?
Thank you. Thank you, Jazz and both colleagues. I mean, my earlier comments when we were talking about winter planning still apply. I think when we are looking at winter plans, I think we should have a resource impact element of those plans, notwithstanding you'll reference it in a more comprehensive financial report. But in that domain, and talking about things which go across all four. So recognising completely that local F&B committees will be scrutinising individual organisation positions, but all of our plans had some level of reliance on system working to address particular issues that enabled us to all put balanced plans in. And I just wonder if we could have an update on how those conversations across the system are going and the extent to which that helps us understand the context in which we have conversations about how more or less challenging the rest of this financial year is going to be.
Who wants to have a crack at that? Leslie, you're looking like you want to. Jazz, do you want to? I see this ball backwards and forwards between the two of you.
I'm happy to start. So I think in terms of the system pieces, Bob, we went into this financial year, I think, accepting that we would have to have a number of conversations with the ICB in terms of some of the funding that we're receiving, the work we're undertaking, and are we being appropriately remunerated as organisations in that space. I think it's fair to say that we probably haven't had the traction with the ICB in those conversations to the extent we needed to, with some of those sort of commitments, I think, now being withdrawn on the back of the ICB saying that it also had a significant financial challenge in terms of its own position, and how do we then square that circle across the system around the funds, and where do deficits fall, where do surpluses fall. So I think it has been tricky, I have to say, but I think we went into it thinking we could actually get some traction. And I think there's a lot of learning for us as we go into 25-26 planning, which doesn't help us sort out the problem here and now, about what we're going to be as a collaborative. You know, what are the conversations we need to have, how are we going to have them, and how we jointly go into that rather than having each organisation, I suppose, leading a separate discussion. That'll be a reflection from me.
What would I say to that, Leslie?
Yeah, so a couple of things. So one of the things that I've asked the all four CFOs to do is to do a waterfall that says, this is what we said our plan was at the beginning of the year. These are the things that have made that very difficult for us to deliver it, both internally. So what were our assumptions in terms of what income has or has not been derived? And then the other bit is, and what are the things we have not done or we have not delivered? Because I think we're going to have to go in here, because if we don't do that, then we're going to go into a discussion that says, you know, all the blame is here, or and we have to. I think we've got to be really open about this. That says these are the things we would have expected from you, be it the ICB or national income, whatever it is, and these are the things that actually we said we would do and we haven't delivered, and that's the start of that negotiation, I think. And given this position, we know that that will be a discussion with the ICB, and also a discussion, I think, pretty quickly with regional and national team. I think so. We've sort of said this in here before, that there is already and this is a contribution in terms of non-income based income, right, or non-earned based income coming into the collaborative, that we need to put in there as well in terms of the open. So we know that even some of that is actually earned. So we need to be really clear about what we believe should be coming and flowing into our ICB and into each individual organisation. And also, sorry about this, you're getting me twice now. That's really bad. And then the work that we need to do and the decisions that we need to take, some of which will be difficult and challenging, but we need to do ourselves.
Thank you. David and Carolyn.
Yeah, thank you very much. And clearly, lots of conversations going on at local level and at APC level. So I don't want to sort of bring those up, but I'm just curious, do we have a number across the collaborative of the amount of work the collaborative is doing that it isn't being paid for? Yes, thank you.
So we're absolutely trying to gather that information, David, in terms of understanding where are we under or overfunded. I think we have to take it around. I think we need to understand where are we delivering more and not being remunerated, but also where are we paid and not delivering enough. So where's that net position for? Because there's no cherry picking the one that we want to talk about. So we do need to do a bit of work, and we as a group of CFOs are trying to gather that information so that we are clear about, do we have a deficit in that funding model? Now, from an ICB perspective, they will say they have given the APC, to Leslie's point, additional top-up funding. That's supporting our cost base. How does that all play into that conversation? Is going to be really important. But the first piece of what we do need to do is, for all the activity we're providing, do we have the right amount of income?
Thank you. Thank you.
Thanks. I'll stay away from the ICB debate. So focusing on things that we're doing, two questions. One was the elective recovery funding. Do we have a sense or management information across the piece of how productive elective recovery is at the different trusts, whether they have similar or different margins at each trust, and that it is a net positive? That's the first question. And the second one was on where we haven't delivered the CIPs that we plan to. Do you have a sense of how much of that is within our control? Because again, in other organisations, I've seen go into the year with this is our CIP, but the plan hasn't worked up at the beginning of the year. So how much of it is we didn't have a plan and we still haven't got one, or we did have a plan, but for X, Y, Z reason, we failed to deliver it? Because you can alter X, Y, and Z.
Yeah, you can absolutely pivot on that one. So if I take the elective one first, I think we're all making a contribution on elective recovery, and that's probably why the data just show that we've overperformed against our plan. Probably what we haven't done is then compared and contrasted if one organisation making 75% contribution on a particular service versus 50 somewhere else, and what's driving that additional cost. So that might be something we just need to get a bit more granular about and try and understand that. Sorry for Leslie, put a hand up. Did you put your hand up, Leslie?
No, I think that's absolutely what we need to. I think the individual organisations may well know, actually.
We just haven't compared it, I don't think, set this one alongside each other. So it might be helpful to do that. I think on the efficiency side, you're probably right. There's two things. When we submitted our plan, I think we all had very good plans to meet our efficiency challenge. Some of those were worked up and started to deliver probably early on, and some of them had in-year effects that we were going to get out. And there's probably some that still needed a bit of work to get mobilised and going. And if you take all of those three things together, there is probably a lag in that delivery against that efficiency plan. And that's a bit that we're trying to obviously always get on the front foot about and say, how much earlier do we need to plan in order to make sure we're crystallising everything on the 1st of April or before, so that we're in a really good position going into each financial year. I think the track record has been, we're getting better at it. I think this year's probably the best we've performed collectively. And then next year, you're going to get into a better place than that. But yes, there is a lag probably in that delivery.
Thank you. I'm going to take two more points, one from Syed and then Tim to wrap up, and then I'm going to move this on. Syed.
Thank you. Thank you. And I completely understand colleagues are working hard to ensure financial sustainability and try to drive up efficiency. How can we assure the board and ourselves that in the middle of all this, quality is not being compromised? I know it's a tough one, but what are we doing to assure ourselves? Thank you.
I can ask you to pick that up as part of whatever you were about to say.
I mean, to that, our key responsibility here is around the quality of the care that we provide, and so we measure all the time the outcome metrics in terms of quality. So whether that's in terms of surgical site infections or anything like that from a surgical perspective, whether we're doing all the BTE assessments on patients as they come in, so patient experience, all of those things we are absolutely monitoring, and we've certainly not seen any reduction in those. And the thing that we have to keep challenging ourselves, and quite frankly, so we need new challenges on as well as non-executive directors, is if it looks as though it's drifting off, are we giving it the priority that it needs to? I think at the moment we are, and we can demonstrate that if you look at the data. There's been no diminution of any of the quality metrics that would make us concerned. Oh, yes, thank you, of course. For individual CIPs, obviously each CIP that we do has a process to make sure that we have assessed the quality impact, and the medical directors and nurse directors have responsibility for delivering that. Yes, thank you.
Thank you.
Can I just make the point I was going to make?
Oh, yes, go on then.
Let's try it, Matthew. No, just it was the point about the ERF and but I think that we probably all know how much additional activity we're doing, and we can allocate the fact that we are spending more to do that activity. The thing I am not sure that we absolutely all have real visibility on at the moment, and I think we have to really test ourselves on, is whether the amount that we have spent to deliver the extra activity is the smallest amount that it could be. And I think that's the bit we need to get back around to make sure that we're delivering the maximum amount of activity to the smallest amount of additional spend.
We still have half a year we could learn that. Thank you. Thanks for that conversation. I've no doubt we will be coming back to that. So I'll leave the conch with you then, Tim. The EMB summary.
Everything at EMB is going marvellously. So thank you, Matthew. I don't think I need to be long. I mean, a lot of the stuff that we have covered already today is the stuff that we have been talking about. We do keep a close eye on the performance. We had a lengthy conversation about the Electrical Orthopaedic Centre, and which is doing, as you say, Matthew, fantastic work in terms of the quality of the care. We do need to get utilisation up. There's quite a lot of work, and we've seen significant progress in terms of the number of patients being referred and rejected. There was an issue with how CPS was. For a lad like me, it was it got into a sort of computer says no approach, where the algorithm was turning down too many patients. That's now been altered, and we've seen a very dramatic increase now in the number of patients going through, which is good, and I would expect that to continue for the rest of the year. We are looking to make sure that we are treating the ASA that grade 3s as well as the ASA 1 and 2 patients who are the less acute patients. So that I think was helpful. Lengthy conversation about making sure that we've got the ethnicity data properly coded and sorted, and then what that means for our EDI improvement plan. And then, of course, we are now beginning to really focus on the clinical pathways projects. All of the chief executives have now had initial meetings, I think, with the pathways that they are undertaking. I have to say my experience has been, perhaps I'm just a natural pessimist, but much more enthusiastic engagement from clinicians than hopeful, which I think is really good. I think there is a genuine appetite for clinicians because they can see this as an opportunity to change pathways and make things better for patients. And I think that, it's pleasing to see that still energises clinicians in terms of what to do. I think the plan is that by next month's APC EMB, we will have the first set of first look of which pathways in each specialty we will be beginning to tackle, and then we can work out which of those are the quick wins that we can deliver in the speediest thing and need to have the most immediate support, and which ones will be slightly slower burns, and then which consultants are in the remedial class. And we will obviously give them additional attention. And then finally, I should say that despite that rather verbose report, I wasn't actually there for the last EMB because I was on holiday.
That's what they would have said if you had been there.
Yeah, which you wouldn't have done it like this.
Now I know how he got through his feedback. Anything else? David?
Just quick question, really. It's good to see the progress on the clinical pathways. I just wondered, Tim, whether there was any view on non-clinical pathway work.
I think that picks up the point I was making about the executive group that met. So that's the wider executive. So the APC EMB is one representative each of the functional groups. The wider joint executive had the discussion, and it fell into that. What are our priorities? We've thinned those out, and then what are the principles that we will apply to looking at processes that we think can be standardized or potentially consolidated across these APC, and it's part of the question is how do we work out whether the view is worth the climb for each individual pathway. So that Virginia Mazzara, who chairs that board, is working with Kevin Croft from the people side, and Jeremy Butler is working to Leslie to energise that whole process. Final thing I should say about the APCMB is that we are going to, I think in the course of this year, think about whether the rotating model in its current form of the rotating cast of characters is making it as effective as it can be, or whether we should extend the tenure of people, and that will go out and have discussions about what the right answer to that question is. But I think what we have discovered is that if people are rotating on off at 6 months, it's sort of a bit of a merry-go-round, and people just get into the habit of how to use the meeting effectively, and then they move on. So very good. Sim.
Thank you, Tim. So my point was going to be on the transformation piece. So government have been very clear about this left shift away from the acute sector back into community. So we have to have that in the back of our mind. And if you think, we've talked about the finances today and how we're not really sustainable and how it's going to be very difficult for us next year. And in a way, isn't the most almost compelling argument that the clinical transformation, if we can motor on some of those elements faster, we'll find our way to a more sustainable sort of future. So the question for me is there any way of enhancing the work, or in speeding up the work in that area, so that we can take the pressure away from the constant, refrain of we're not sustainable? Because it's not going to get any better, is it? There's no extra money coming our way, and demand isn't going to go down. So we have to do something different in order to be able to consistently deliver for our residents. Tim.
Thank you. That's a very cheering assessment of the situation. I think that a couple of things, I suppose. Well, I think three things. So the first thing is, yes, I completely agree with you in the medium term. I think we need to understand where our clinicians currently are. And one of the things that we need to use this process to do is to build the relationship so that we can then make genuine progress once they have, because these are people who have basically been competing with each other for 10, 20, 30 years. So we need to get through that bit. That's the first thing. The second bit, I think, is that there is, at an ICB level, there are clinical reference groups for most of these specialties that have primary care represented on as well. And what these four clinicians from each specialty should be able to do is to slot into that group as a sort of black box for the APC. So in other words, we can make sure that what goes in terms of referrals and out in terms of discharges from services joins up with what we want to do in the middle, and so streamline that whole pathway from the patient at home through whatever needs to be done back to the patient at home with the GP. So there's that bit. And the final element of this is that one of the things that our colleagues in primary care are really concerned about at the moment is that the system is too disjointed, and there is a feeling, rightly I think, that we haven't made enough collectively to work together to put the patients, build the pathways around the patients, and this sort of system integration work is incredibly important. So Claire has been leading on some of the system integration work. Martina Deneen, who did a lot of the really good work on the EOC, is now working to me to help broker those conversations with primary care, and those will come back to the planned care board of the ICB, which I jointly chair.
Great, thank you very much, Tim. I'm going to move us on to the executive and chair standing committee reports, which we now bundle together. So, David and Pippa.
Okay, I'll tell you what we've been up to in the last 3 months. Many of you will have heard we dealt with another industrial action, which was our MediRest staff. It was a trickier one because they're not employed by us, they're employed by MediRest, and QB headed the dispute. Because Jonathan had handed in his notice, we sent him in to go and do the compromise as a painfulness, and actually managed that really well. And we have managed to resolve that. We've agreed London living wage with MediRest, who are the employer, and some contractual alignments, which is actually what part of most of the dispute was. The benefit for us is we've now become London living wage compliant as an organisation, which is a really positive, and we were very much committed to achieving that. So it did have a great benefit. We opened up our £20 million 32-bedded acute
You're not
medical.
going to do every paragraph, are you?
No, medical. The reason I'm shouting that.
Even if she speaks really, really quickly.
I'll say it all and I'll say it quickly. My paragraph now. The reason that's important is it starts to right size the organisation for the increased demand through A&E. We have also future-proofed it and built 2 mental health compliance rooms in there, which too is nowhere near the size of the need for our mental health patients, but it's a start. We've got the £30 million community diagnostic centre at Ealing, which is fantastic and really starting to come on board. So lots of great estates work. We have launched now, the first in the country to launch the compound equity index. It's got lots of interest. It's really starting to deliver some of our inequality work within the organisation, which I'm sure you'll hear much more about. And a shout out for the comms team, who we were voted as assessed as having one of the most accessible websites in London. Really important for us, for the communities that we provide care for. We've talked lots about operation and finance performance, so I won't go into that. Just a shout out for a couple of our staff, actually. So one of the biggest ones is Roseanne Wanker. She was awarded last night at the Parliamentary Award as longest serving long service award from Amanda Pritchard. It's fantastic. 49 years she's worked at Central Middlesex. Was previously competed in the Olympics and was known as one of the fastest women in Africa. She is phenomenal. I think we all miss her running around our operating theatres, but it was really nice to have her celebrated last night, and many other achievements that you'll see from our staff. That's it.
Thank you. Do you want to add anything from the steering committee?
Just 2 bullet points. One is, and both we've spoken about them both, but it's a point of emphasis. The complex mental health needs of patients attending, and the other one is a financial challenge that the trust face. Those are the 2 flashing items that I'd like to emphasize. Thank you very much.
Thank you, David. Moving on to Tricia and Carolyn.
Thank you, Chair. So I just want to highlight a few things, some of which Matthew's already covered. So in terms of key messages from the Trust, we have been under considerable scrutiny from the CQC over the last 3 months. None of that was unexpected, in that we had been given a heads up several months ago about the fact that we had aged ratings both at the Hillingdon site and the Mount Vernon site. So Mount Vernon hadn't been inspected since 2015, and Hillingdon had inadequate ratings in 2018, and the CQC have made clear over the last couple of years that they would, as part of their catch-up inspection regime, would be coming to trusts who were in those situations. So so it wasn't unexpected, and overall has been a positive experience in working with the CQC team, but has taken up a huge amount of operational time over the last 3 months in terms of preparing for and responding to those inspections. The CQC had also informed us that they would do a well-led review as part of those 2 lots of inspections, and that we believe finishes today with attendance at the board meeting today. So we will await our feedback from the CQC in terms of formal reports sometime in the next month or so. We did receive some immediate feedback following the inspection at Hillingdon. I think the important bit from that has been highlighted in a number of the reports today, which is that we already had a number of actions underway. If you look at our emergency and urgent care report that was reported earlier around ratting, safety huddles and so forth, and what we have been able to do is really ramp up our response to that. So some positive outcomes from the inspection. I think it's important to note that in our finance report, you can see that we are under a huge amount of pressure financially. We have a number of actions in place in terms of our financial position, and are absolutely committed to minimising any spend over our budget where we can do so. But we are, like a number of the other trusts in the APC, under huge emergency pressure, and have seen a significant increase in expenditure in relation to that, and in relation to pressures associated with patients with mental health needs. So we are at the moment looking at where we can identify those pressures that are outside our control and those pressures that are absolutely within our control. We continue to outperform our position in terms of operational performance, and huge credit to the team for that, although our A&E position is not where we would want it to be. And then I think, again, a number of things have been covered in the report. I suppose my final thing just to say is that the Hillingdon Hospital redevelopment is really important to us in terms of the long-term quality of care that we can provide. We are awaiting the national announcement on that, which will now not come until after the Chancellor's budget at the end of October, but we hope we will hear in November where we are on that pathway of care. We are not in any shape or form stopping the work that we have underway, which is our Decant and Enable programme, so that we can clear the site in anticipation of us getting the go-ahead for new build. So that is really positive, and there's some really good work going ahead on that. So I'm not going to say anything else. I think most things are in the report and are there for people to read.
Thank you. Carolyn, anything you want to add from the standing committee?
I think just to expand on what Patricia said, which is very fulsome, is that we did get, as a result of the inspection of Hillingdon, a Section 29 notice, which I think we've responded to extremely promptly and fully. So I think we've got one more to respond to still by 5th of November. And I, like you, Matthew, would like to put on record my thanks to all the staff who I think had a really difficult 3 months, frankly.
Thank you very much indeed. Thank you. Bob, Tim?
Thanks, Matthew. I've written an enormously long report, which I will not go through
Well, we were hoping you would read it.
Paragraph. Well, you're sitting comfortably. Right. So I'm going to pick out. So I've covered most of the operational issues, so as I will go into those. Firstly, just a big thank you to Carolyn, who we've lost to Hillingdon, and to thank her for chairing our quality committee so expertly, and we're delighted to welcome her as our new non-executive director. Things of excitement I'm going to mention. So the first is we've launched a design competition with the Royal Institute of British Architects to design the Fleming Centre, which is going to demolish my office and indeed yours, Matthew. Yes, and so will be in a tent whilst some world-class academics research antimicrobial resistance. Lord Darcy has done an amazing job of raising £100 million to kickstart the Fleming Initiative, and the centre in Paddington, which hopefully will open in 2028, will be the centre of a network of other Fleming institutes around the world. So that's a very exciting development. In terms of the new hospitals programme, which was mentioned, obviously there is a pause. I think that could be good news for some areas because it obviously got moved down by the last government. I think if they recalibrate the programme based on need, I suspect it will move back up, and we are waiting to hear whether our funding to get to planning will be approved. It's apparently sitting on the Secretary of State's desk, metaphorically. I mean, I'm not sure it is literally. But, really pleased. Janice and the nursing team did a fantastic job to get us a Pathway to Excellence designation for Charing Cross. That has really actually been incredibly empowering for our frontline nurses in terms of improving their ability to actually have the confidence to tackle things that make their daily lives a problem, and it's been really nice to see, and that is now going to extend across, and we'll try and get across the other campuses, which is splendid. We saw yesterday at our executive transformation session the result of now a 4-month piece of work on our cancer pathways. I had become concerned that our cancer pathways were too disjointed and not focused enough around the patient. The treatment that people were getting was good, but I think it was not, that the pathways are not really well enough joined up around the patients, and we have mapped each tumour pathway for some fantastic work with the Helix Centre around engagement with patients who have experienced our pathways, and we're now putting together a plan where we hopefully can readjust those to make things better for patients. important to note actually that one of the issues, which is a good issue to have in some respects, is that because more people are surviving cancer now, one of the big pressures is actually the oncology service is really creaking, and the country hasn't quite trained enough oncologists, so that we will need to think really carefully and imaginatively about our cancer workforce. And then we're full of initiatives at Imperial College Health Care. I mean, we've also launched Improvement for All, which I'm also really excited about, which is a mechanism for, again, using improvement methodology. We have a fantastic improvement team. They tend sometimes just to sit to the side of what's actually going on. This is a mechanism for us to bring improvement to every single ward and department, and to get the ward sisters to own the improvement plan, and basically to combine everything they need to do into a single improvement plan, rather than having an improvement plan for multiple different sets of visits and inspections and all the rest of it. So we're again very excited about that. I'm going to skip over most of the rest in terms of operational and financial performance, because we've covered most of that. We had a fantastic event to launch our anti-discrimination, anti-racist statements a couple of weeks ago. We had the Cabinet Member for Health for Westminster City Council came. I think it was well received. We launched the pairing of all of the exec with some of our VAME staff at that event, and again, I think we're very excited about that. You've mentioned Kevin Jarrell retiring, which is a great loss, but Robbie is a fantastic appointment, which we're delighted with. Just to note, we've appointed Matt Ayres as the Hospital Director for Charing Cross, and Stuart Cooper has just joined us as the new Divisional Director of Operations Medicine. And I'm delighted that Andreas Raffel has accepted the job of Chair of Imperial Health Charity, and Andreas used to be one of our non-executive directors and previously a Vice Chair of Rothschilds, so that is fantastic. And Mark Thurst has been appointed the Director of the Academic Health Science Centre. He is also, of course, our BRC Director. Finally, just on research and innovation, this did come up at our standing committee, and we had an interesting conversation about it. Just to note, I'll give you one little snippet, which comes from a rather lengthy paper that I've had in response to that, which is that in the last 4 years, Imperial College Healthcare has recruited 85,727 patients to NIHR portfolio studies, which is more than any other hospital in the country, which we're obviously pleased about. We are collecting a range of other metrics to demonstrate where we are brilliant and where we can do more, although generally I have to say, having looked at these, we're quite brilliant across the that is entirely possible. We've had 5,400 patients signed up to the Imperial Healthcare Knowledge Bank now, which is great, and currently just trying to develop our approach to the use of AI and how that is a governance structure that will allow us to be agile enough to take advantage of opportunities, but strict enough to make sure that we are comfortable that data is being used appropriately. The estates. The education centre at St Mary is reopened in September. It looks fantastic. Anybody who wants to come, we've turned the Mint Wing into something very, very nice, which is a difficult thing to do, as it used to be the post office's stables. But that it will replace the library, which will sadly close in the medical school building when it is handed over to the new owners. There's a list of people that we've engaged with, which is long. And there's a list of pleasing recognition of success, particularly pleased actually to see that the inclusive recruitment that we have launched been shortlisted for a number of awards, including the HSJ awards, and we've got 5 other categories.
Bob, anything you wanted to add from the standing committee?
Well, I'll start at section 2. The most important thing is that through appropriate discussion and reporting, the Trust Standing Committee obtained assurance that the local committees were appropriately overseeing areas of responsibility. And the big learning point for me is I either need to get better at landing an agenda or chair better, because getting through that summary agenda in 2 hours proved to be quite tricky.
Thank you, Rob. And lastly, Leslie and Steve.
Thank you. I'm not sure I should have followed Tim actually, but anyway, so thank you very much. So I just wanted to link actually a question around violence and aggression and the work that we did following the unrest earlier in the summer. And we, although it was really uncomfortable at the time, we did really the communication with the trust and particular communities that both work and are treated in our trust. In this case, it was particularly at West Mid, actually, to inform some of the work that we've been doing with our communities and with our staff and the EDI agenda. So although it was really uncomfortable, we did, I think, use that well. We've talked a bit about, I think, in terms of all of the quality, the options and the money. The ambulatory diagnostic centre continues. We have opened the new therapy department. So those of you who haven't seen it, it is really nice actually. So there was a lot of unrest about that in terms of the movement, but that's worked pretty well. And you will see linked to my first commentary, the work that we've been doing, particularly with so comms, CPO, and indeed Natasha Singh, and who's our diversity champion, have been doing with particular communities. You'll see the work that Jonathan has done. He's been a real find actually in terms of work and leading that research work. I should say actually this week is our 5th year celebration of CW Innovation, which again celebrates our innovation and improvement work. And we did a webinar yesterday with staff around some of the work that our Horizon Fellows, so our Improvement Fellows, who are all members of staff, have been doing to improve stuff across the organisation. And then you will see some of the recognition. So I want to say something about the National Patient Safety Award that went to the critical care outreach teams. This sort of speaks both to the Martha's Rule work, but also to the real drive to try and respond to deteriorating patients. It's a problem that all of us have, and they won the Patient Safety Award, which I think is absolutely commendable. And then also the work that our maternity services have done, which, thank you to colleagues at CQC, have been used as some of the examples of best practice, including the use of other health safety champions. Say part of Pippa, I mean, I think you started that work actually, so thank you very much for all of that. There's lots of other stuff in there, but thank you.
Thank you. And Steve.
Yes, thank you. So I would just like to pick up the point that Leslie made right at the beginning about the work that was done around the civil unrest. I think there were 10 calls with staff, and the feedback around that was it was very uncomfortable, but it was incredibly well received. So out of I think that was an outstanding piece of work. We've talked through the operational stats, which are extremely good, and the maternity report was also extremely strong. And the only thing that is on there for escalation is that we do have a concern that the financial performance needs to continue to improve, because just like everyone else, we do have a deficit. It is perhaps quantum somewhat smaller, but it's still a deficit that we need to resolve. Thanks.
Thank you. Thanks, Steve. Excellent. Is there any other business that anybody wants to raise? Otherwise, I'm going to take us into questions from the public. Excellent. Thank you all very much. Okay, I have had a couple of questions given in writing, and then a list of questions given us in writing, but which was suggested, and I agree, we should respond to in writing, and we will post on the website. So thank you for the questions, patient voice. Kind regards. There was, Robin, are you back with us? I know you had to disappear during it. If so, I'll ask you to describe your COVID question. Otherwise, I'll read it for you. You are. Excellent.
Yes, indeed. Thank you. Well, I just would like to thank on behalf of patients all the staff and volunteers for the incredible dedicated work revealed by the papers, especially the Chief Executive's reports. And I do think they're worth wider diffusion, perhaps a task for the new Chief Information Officer covering the collaborative as a whole. But my question is just asking you for an update on the COVID situation. So I'm aware that the Pet Rose Clinic didn't hold all its appointments yesterday because the lead consultant, Peter Seaver, has COVID. And I myself have received doctor letters from Chell West about an appointment tomorrow with information about COVID, although the enclosures questionnaire were missing. That's doctor for you. But we're not, I didn't read in the papers, all 270 pages, any reference to this virus. And I wonder what, how much alert patients and indeed staff should be displaying in the current situation, that we're in. That's my question. Thank you.
Thank you.
I'll take it.
Go on then. Excellent.
So at the moment, we're not seeing a rise in admissions associated with COVID at all. If we are finding COVID, it is because somebody has been admitted for something else and they've been screened because they have a respiratory condition. So we are not admitting patients for COVID. I think that's important. It's not contributing to our operational pressures as it stands at the moment. We are starting at London North West to see some flu cases though. So just to say, if anybody's in the room and is entitled to a flu vaccine, please have one, because the flu season is coming and it is starting to come upon us. Anecdotally, we are hearing stories of more staff having COVID, and we have got a small rise in sickness. But operationally, particularly London North West, obviously we see the highest volume of emergency patients. It's not affecting us operationally presently, but we continue to monitor it, obviously.
Thank you, Roger, and then I think Julie wants to say something as well.
Thank you. So whilst flu vaccination is obviously very important, COVID vaccination for our sensitive, also important across the APC conducting vaccinations, and I would urge everyone to take that opportunity up if it's available to them.
Thank you. And Julia.
Yes, I think it's important to note that at a national level, there are around 3,000 patients in hospital at the moment with COVID. I agree the majority of those may be not because of COVID, but with COVID. But there is a rising number of COVID cases across the country. London's been unusual at not seeing the same rise as the rest of the country, but that's not going to last. And there will be a rising number of cases in London as well, which will affect us as we go through the next few weeks.
Thank you. Thank you very much. If any members of the public want to ask a question, please raise your hand. Otherwise, sorry. Eyes in the back of my head.
Sorry.
Yes.
I do have two, well, start with two questions. One that came from patient story, which was that you mentioned that very quickly that the patient had been referred by their GP. And I thought very lucky of them. What happens, happening a lot of times, if they can't get through to their GP? Can the same sort of referrals be done via 111 beforehand?
Yes. Yes,
I was going to ask that question. I didn't like to.
And that's the point of the single point of access number. So yes, I emphasise the fact that it was some GP, but equally 111 has that referral pathway as well.
Go on, 30 seconds ago.
Yeah, the second was a question that actually came up originally at our Ealing Primary Care Executive Group. And it's a worry they had for GPs. And it was a challenge to their budget in that a lot of hospitals were actually prescribing fairly costly drugs for their patients before they were sent home, and they expected their GPs to actually continue with these particular drugs, in a nutshell. And this was challenging the budgets for the GPs. I don't know if there's any answer to that at all, but if you'd like to note that this challenge has come up via the PC networks.
So that is the way that the system is funded, that is what happens. The thing that is important is that what we're providing, either as inpatients, for inpatients or outpatients, are the appropriate drugs for the patient's condition. So if you go back 30 years, there was a situation where hospital doctors would have prescribed often proprietary brands of drugs, and they were often really quite expensive and a variable cost. We now prescribe almost every drug in a generic way. So in other words, the cheapest brand of that drug will always be dispensed, and so the drug may be expensive, but that is because a clinical decision has been made that is the right drug for that patient at that time. And nearly all of what we prescribe is in line with various forms of guidance that come from the National Institute for Clinical Health Excellence and other things. So it's sort of, I can understand that it's a pressure, but actually it is the way that the system is meant to work. What we do need to make sure is that we do prescribe the full, it's normally on discharge from hospital, it's normally 14 days. We do make sure that we do prescribe that whole course so that they give the patient and the GP enough time to take up the cudgel.
Thank you. Thank you. Robin, you have a second question in writing. I don't know if that's what you want to come back to.
It wasn't my question. My colleague Gaynor sent her apologies. She couldn't get here this afternoon, but she did have an important question on the elective orthopaedic centre. And both you and Tim have referred to the issues and said that the anaesthetists and the algorithm are relevant. But I wonder if more publicity is needed about the success of the treatments there, and more public awareness is promoted, as it were. Again, a task perhaps for the new Chief Information Officer. I don't think many people, have fully grasped what's on offer there. We're very anxious to see it succeed. Thank you.
Shall I throw that to you or?
Yeah, happy to. Thanks, Robin. So what I would say, in terms of experience and patient outcomes, have been excellent. So 100% positive patient experience from the Elective Orthopaedic Centre, and that's from patients across the whole of North West London using it. Absolutely no issues in terms of travel, access, like I say, positive experience, very positive clinical outcomes. The issue has been how do we ramp up the service to that? It was an ambitious business case, and it literally had the orthopaedic centre working at full capacity from day one, which, in hindsight, we should have probably built in a build up to that. We have alluded to some of the issues we've had with the aligned digital platforms and the algorithms working in that, which we've now corrected. And what I would say is the clinicians have been very, very supportive from all organisations and very positive about working in this model. So we're confident we will get to that delivery plan by the end of the year, but it has taken longer to build up to it. There is no need to advertise it. The patients are there and we're getting the patients onto the right list. They are also being operated on in their own hospitals as well. So this isn't a case of they're just sitting on a waiting list. They either are being operated on in their own local trust or in the elective orthopaedic centre.
Not as well.
Thank you very much.
Robin, you had a last question about on the staff bullying point. Did you want to raise that?
Yes. Well, I think I read those papers with concern, because we know staff are under pressure from the workload, and that they should be under pressure from the behaviour of some members of the public is very concerning. And the more can be done to get the message across that everyone must treat everyone else considerately, it's very important. I mean, I'm afraid notices saying bullying is not tolerated don't have any effect on bullies. It does need, wider work. And I mean, this is a problem for society generally, not just for hospitals and so on. But the rise in violence in our communities is worrying. And I think people don't realise how difficult it makes the job of NHS staff. So more work can be done to get across the need to behave properly, the better. I don't know if more ideas.
So thank you.
Thanks, Robin. And I think one of your key things there was, where you're absolutely right, is don't bully people is as a notice, is an incredibly unhelpful thing for people who are likely to bully. I think there are a few important things, and certainly a lot of it we need to try and resolve by some of our basic operational issues. So people who arrive in emergency departments in acute mental health distress will behave badly because it is absolutely the wrong environment for them. So it's beholden on us to make sure that we take that operational step to try and decompress those sort of situations. Similarly, there's a bunch of stuff we can do because people get angry when they get tired and frustrated, and they come to our emergency departments when they are sick and frightened and vulnerable. And there's an awful lot we need to do, we've set up, I think every trust has set up a group around this. I certainly chair the one at Imperial. And one of the things I think we have to be really careful about is not to create a narrative that says that the patients and the relatives are the enemy. I think it's really, really important because actually a lot of them are just sick and vulnerable and scared, and it's a difficult situation, and we haven't contributed enough to make it. So we do need to think about what's the environment, what are we doing to make it a more conducive environment, what are we doing to give people information about how long they'll have to wait, and all of that sort of stuff. Then there is a bit about, yes, in the major trauma centre, we see quite a lot of gang violence and quite a lot of those sorts of things. For these behavioural issues, we have found there are some interventions that are very helpful. We're rolling out training to staff to try and de-escalate sort of flashpoints. We're training people in the use of body-worn cameras, which are actually quite effective in when the patient and the relatives know that the body-worn cameras are on, it undoubtedly modifies their behaviour. And then there's a really big piece of work for us to do about how we support our staff in the immediate aftermath and in the longer term. Because I don't think we're going to get rid of these incidents. We need to try and minimise them where we can and support our staff when we're running into trouble. But I think across the whole of the APC, we're all very, very seized on this because it is a worry for everybody.
Great, thank you, Tim. In the absence of other questions? Sorry.
Sorry, more of a request. I do believe tomorrow, starting lunchtime, is the ICB board meeting. I was particularly worried by it, but I would request that if somebody's there, have a look at item 10, which is all about integrated neighbourhood teams. I really don't think it's been worked out.
I'm sure you will go to the ICB.
Yeah, I have sent some questions in already.
Very good. Excellent. I look forward to reading them in.
More people who are aware of what's going on would be better.
Right. Thank you. Thank you very much. Thank you for our visitors. Thank you to the executives and the NEDs. And I am there going to close the meeting. Thank you. We'll have a 15-minute break and then come back for the meeting. Bang on time.
Perfect timing. Very impressive.